but first board meeting in public, so welcome to Hina Khan. You may have seen her showcasing on Breakfast TV a few weeks ago on the role of GPs in the community and the struggle around accessing some medication. She did a fantastic job. We've also got our colleague Chris Harrison, who's joining us online today. Carmen Drinkwater, one of our non-execs, is running a bit late. She will be joining us, and we've got apologies from Rachel Jones. We are scheduled to finish at 2:45, but we do have a break at 10:55 and also 12:30 for 30 minutes. But as I say, we'll try and be as efficient as possible with the agenda today. It is Wednesday, so we do have a fire alarm test, but unless somebody indicates differently, it is a test. You just need to do anything at this stage. But obviously, if there's any change to that, we'll indicate to colleagues. We are in the pre-election period as well, so just remind colleagues of that in terms of our discussions and any sensitivities that might be related to that. I think that's everything. So as always, we'll start with a patient story or a colleague story, just to remind us how important this is in our decision making, and how the impact of our decisions are in terms of colleagues and our patients and the public. So we've got James and John with us today, who are going to take us through a story that has been impactful, and then we'll get an opportunity to ask any questions. So over to you, John.
Good morning, everyone. My name's John, and I'm part of the patient experience team. And I'm here with James today, who's from the theatres group at Salford. And he's going to share a recent policy that, along with his team, he devised to support and enhance the experience of our patients with specific requests following surgery. So I'll hand over to James.
Thank you. So I'd just like to share with you a patient story that we had up in theatres. So a patient underwent an emergency lower limb amputation in our trauma and orthopaedic theatres here at Salford. Following surgery, the patient made a deeply personal request. He wished to take his amputated limb home with him so it could be buried in his garden. The intention behind this was that he could have it buried with him at a future date. To our knowledge, this request had not been made previously. It presented significant clinical, legal, ethical, cultural and organisational challenges. There was no existing Northern Carolines policy to guide this situation, and multiple internal and external services needed to be involved, including the mortuary, governance, the legal team, solicitors, infection control, health and safety, surgical teams and the local council. So our responsibilities were to ensure the patient's wishes were respected while maintaining safety and compliance, to coordinate multiple departments and external partners, to identify and manage legal, clinical and organisational risks, to keep the patient fully informed throughout, and to develop a clear and patient-centred and sustainable process for the organisation. So we applied 3 R's model. So the reality of the situation was that it was a complex and sensitive situation. There was no existing policies in place, and it required a multi-service collaboration. The response was acting promptly, coordinating expertise across the team and keeping the patient's needs central. And the result was achieving a safe, individualised outcome, and we established a sustainable and organisational process if any future cases arise. So to keep the patient at the centre of the decision making, we adopted a structured and collaborative approach. So some of our immediate actions were: we contacted the mortuary for urgent advice and confirmed that there was no trust policy in place which covered this type of request. We arranged a safe transfer of the limb to the mortuary and agreed temporary storage for up to 1 month while the solution was explored. So it was really, really time sensitive. So we clarified that if repatriation was not achievable within 28 days back to the patient, the limb would need to be respectfully incinerated. We communicated clearly, sensitively and compassionately with the patient and explained the interim arrangements and provided regular updates to him. We had cross-service engagement throughout the trust. So we established and escalated the situation to the Deputy Director of Nursing. We sought guidance from the governance team, who recommended engaging the trust solicitors, consulted with infection control and health and safety to assess the risks and compliance requirements. We engaged our surgical colleagues and trauma specialist nurses for clinical and operational input, contacted other NHS trusts to benchmark practice and confirm the lack of national guidance and any other policies. We also needed to liaise with the local council, and we needed to understand the legal requirements surrounding burials in the community that are not within kind of cemeteries and other such areas. And then we needed to brief the secretarial and administrative teams to ensure consistency in future cases. So we communicated and collaborated, and we coordinated discussions across all involved services to ensure shared understanding and joint decision making. We advocated consistently for the patient's cultural, religious and personal needs and embedded equality and diversity considerations. We maintained open, honest and compassionate communication with the patient throughout. We ensured that it remained central in the process. From a service improvement point of view, we work with solicitors to develop the appropriate documentation and a formal letter for patients requesting the return of body parts. We led the development of a new organisational policy through the Theatres Policy Group, which is part of the Theatre Excellence Programme. We supported our trauma specialist nurses to create an accessible patient leaflet. This included translation and alternative formats, which are now available on request. And we ensured the new processes were practical across all NCA sites, and we aligned these with legal and best practice requirements. So obviously all our hospital sites are quite different. They've not all got mortuary services, so it's quite difficult to kind of sort that out really, because some of the mortuaries are shared. So the result was a safe and legal and respectful plan, which was successfully implemented. We ensured that the patient's wishes were honoured while managing clinical and organisational risks. A comprehensive policy now exists with a governance framework, and patient information leaflet are now in place across the entire NCA. Staff have got a clear and standardised process to follow for similar requests in the future. The work strengthened cross-service relationships and improved multidisciplinary collaboration. Most importantly, the patient felt listened to, respected and supported during an extremely vulnerable time. His wishes were upheld, and it resulted in a positive patient experience and outcome. Take any questions?
Brilliant, thank you for that, James, and thank you for all of your work on this, pulling together what sounds like a really complex set of circumstances as well. So, colleagues, can I just remind you as well to use your microphones when you requesting to speak. So we've got a couple of people already wanting to speak to us. Suzanne.
Yeah. Thank you firstly for sharing that. I don't think I've heard such a patient-centred application of the 3 R's process before, other than the one that you've just shared with us. So in terms of that methodology, just some feedback about how it worked for you to use the reality response result methodology in all the work that you've just done.
So we've applied the 3 R's in retrospect, because this is kind of a couple of years old now. It obviously took a good 12 months to get the policy properly in place. So yeah, in retrospect, it's something that I would definitely use going forward. At the time, it wasn't as much of a big thing, so it's something that we've kind of become aware of since, really. But yeah, it's been good to reflect on and use it.
Brilliant, that's good to hear, because it's methodology that we're engaging across the trust.
Yeah.
Approach to quality improvement. So it's good to hear it's been a successful approach for you as well. Thank you. Jeff?
Thanks, Joe. I just want to say a huge thank you for what you did. In public service, it's very easy to say to unusual requests. Sorry, we don't do that.
Yeah.
We want it. So the easy way out was there. I need to take it. So I think you've represented trust brilliantly. Thank you. Excellent example of policy. Interesting that nationally there wasn't one. I was wondering whether NHS want to pick up on what you've done, make sure others know what to do next time they request a management of treatment. Thank you.
Because there still isn't a policy. There still isn't anything nationally. I checked last night, and if you Google such incidents, you get like sample policies don't from different trusts, but the only one that actually comes up is our policy.
Julia.
Thanks. I think it's following on from Jeff's point. I think it is something that would be worth presenting at a conference. It's an appropriate one because not just the outcome that you achieve for the individual, but how complex some of this work can be. So I think back to that because this is what it is. It's a living, isn't it? It's I think it would be really good. It is very, very cross specialty, multidisciplinary, inside the organisation. It's really helpful. Anything to share, I think. And I think you've got to do that. What are the things that you've learned about that approach that you would recommend to others?
Yeah, it was like the policy development side was huge. It was really big. We obviously managed to get a quick outcome for the patient because we needed to, because it was so time sensitive. But then the policy itself took a good 12 months to follow.
Any other questions or comments? I wonder, is this because there's some fairly strict guidelines around sort of human tissue regulations, and particularly our mortuaries are guided by those. Was there any implications that we were able to draw on, or were there some gaps there as well in terms of that?
Not really. It's more around the local council. So obviously, if there's kind of a public health or an infection control risk, then it's not something that we can pursue. But providing there isn't, which a lot of our limb amputations tend not to have those implications, so it is doable. But yeah, it was a challenge at the time. Yeah, it was very challenging. And the big thing with it is, obviously, from the local council perspective, they need to be aware that potentially body parts are buried, if they're found in the future. So it was the local council side that was quite big as well.
Yeah. Okay. Well, listen, really appreciate you coming to sharing your story with us at the board. I think it's a great example of, as we said, patient-centred, but also the complexity of challenges that we wouldn't necessarily think we're going to be dealing with on a day-to-day basis, and then the range of colleagues that need to be involved in terms of addressing that, particularly when there's that lack of national guidance. And hopefully this is an opportunity to implement what others are doing, because I'm sure it won't be the first time that request has been asked. But as Jeff says, it's probably something that's hipped over, taken as seriously as we have done here. So thank you for that, and thank you for all that you've done, and for you and John to bring it to our attention.
Thank you very much.
Appreciate it. Thank you very much. You're welcome to leave us. You're welcome to stay at us as well. I'm sure you've got other things to do.
Thank you very much.
Thank you.
Thank you. Just no worries, we got your message, we let everyone know. So we've just finished the patient story, which was on to declarations of interest. So are there any declarations of interest that everybody's need to know? No, if there are any that arise, let us know through the post meeting. It's got minutes from the previous meeting. Is there anything that colleagues want to raise in relation to the minutes? We happy to approve those? Yeah. Thank you. Okay, and in terms of matters arising, we've got a specific report on to follow up around 7-day services. So I'm going to hand over to Rafiq to take us through that.
Thank you, Chair. And in the interest of brevity, just a couple of things I want to highlight. So this is on the back of our discussion related to 7-day services.
And he asked to clarify what our plan forward will be in terms of delivering that. Having discussed with colleagues, I think the bit that's worth just pulling out is we've used the term value shift plus in there, which I think we've realised that some board members might not have been exposed to. But essentially, it is the expanded version of the medical workforce programme, which is part of the NSP. So medical workforce essentially rebranded and expanded to cover all our CSUs, and is a significant part of our CIP and FSP work this year, and builds on work that we've done with PwC recently, which quite heard about. And there's essentially an emphasis on alternative workforce job plan alignment, getting job planning right, and ensuring that we then have sustainable services that can use these tools as part of the regular cycle around the year. And the other key takeaway is, having looked at it in detail, we are proposing that there isn't going to be a standalone 7-day services project that is separate from the other things we're doing in the trust, but we're going to link this tightly with the FSP work and the reviews of our CSUs now that we have rolled out CLM. So we integrated in that, prioritizing our 7-day services and emergency care cover. And we're also proposing, because it was part of the discussion, that our very first priority is going to be acute medicine, as described in the paper. And not the chair, assume people have read the rest of the detail.
Okay, thank you for that, Rafiq. And if we can just remember to use the full terminology, just mindful that everybody might not understand all of the acronyms that we use, and there's plenty of them, isn't there, in the NHS? So if we can try and remember that, and that goes for all of us, that'd be great. Okay, colleagues, has this already been to quality or people in education?
No, Chair, it has not. This came as a asked to dice.
Okay, thank you. Chair.
That's it. I just wanted to clear about those applications. On a service basis, will this be expected to be cost neutral, or will we expect to be cost neutral across the whole of the programme over the year it takes to run through?
Thank you, Jack. The expectation is that it will come within the target CIP for each of the services. So the initial target will be to essentially deliver the CIP and in the reshaping of the service, deliver 7-day services. We anticipate that in some situations that might not be possible, in which case it will be balanced across the programme to ensure we have the ultimate.
Okay, thank you. Hina?
Thank you, Chair. I just wanted to check, one of the biggest challenges that we had with this is the job planning and the rostering and the consultation period. We're trying to get the 7-day service with our current workforce. So just moving forward with a view with that, will we be ensuring that when we're recruiting, that will already be factored in moving forward, so that actually, you know, that's kind of already set for us?
Yeah, so job planning is an area that we continue to make improvements in. We now have a job plan completion rate that enables us to have a reasonable understanding of the things that are happening around the trust. And essentially, the next step will be to ensure that there's that flexibility of changing job planning within the policy, because the policy allows changes within 3 months in response to evolution of changes in services. And this is what we're going to invest a lot of time and focus and training in over the next cycle to ensure that we have that flexibility across our services.
Okay, any other questions or comments? Can I just check in terms of the governance then, how are we going to assure ourselves that we've got that consistency and fairness across the board if we're using differential levels of governance, and we're not having a bespoke to understand it's going through different routes? How are we going to assure ourselves that we're achieving that consistency and fairness across the board?
Yeah, the bulk of the changes will essentially flow to Clinic Portfolio Board, the big bits, because it sits under financial sustainability plan as opposed to speak. Where there is impact on things like quality people, it will flow to the appropriate committee, and then we'll report it to board. So most of the change to the Portfolio Board, but there will be elements of this in including our annual reporting on 7-day services, that flows to the education committee, for example. So elements will flow to particular.
Might be something to pick up, Carmen, in terms of following that through to make sure that, it's you're clear how that's going to feed into and how it's going to touch on the quality committee of this as well. Thank you. Okay, so we've got 4 recommendations in the report. So that's to approve the approach, approve the governance and assurance arrangements, support the prioritisation of acute medicine within cohort 1, and note the benefits realisation. Are we happy with all of those to approve those 4 recommendations? Yeah, okay. Thank you, colleagues. Thanks, Rafiq. Okay, so we're moving on now to the action tracker. I don't think there's any actions that are outstanding. I think they're all completed as far as I can understand. Has anybody got any other in progress? They're not due to come back until September or July. Any questions on the action tracker? No? You still got your light on? Yeah. Okay, thank you. Okay, perfect. We have to accept those in train those actions, and we'll move on to the chief exec's report. Owen.
Thank you, Chair. And again, just sticking to the principle that you established at the beginning of the meeting, I'll take the report as read. What I will do though, prompted by Jeff as the meeting, is just maybe just reflect and add a particular point that we are kind of in a moment several, but particularly moment at this moment in time in respect of anti-Semitism. And I think it's just worth maybe just reflecting on that. And one of the things that Jeff helpfully did was just remind me about, for example, the work that some man or man had done around some of this. And I think there was also Penny Morden involved in that piece of work, which was Lord Man's review around anti-Semitism generally and its presence within the NHS. So this is not just an outside societal issue. There's some work for us to do, particularly with the communities that we serve. This part of the Northwest is something that we need to have regard to. And I'd probably just add that also needs, also I'm sure the board incorporates, what's our view on things like Islamophobia and a more general piece around some of this. And we need to make sure that as an organisation that we're leading with our behaviours as much as possible and modelling the kind of behaviours we want to encourage amongst our colleagues who work here, but also the service users who use our services. So I just want to add that in addition. Chair, thank you. Happy to take any questions on any aspect of the advisory scale.
Thanks, Owen. There's quite a lot in Owen's report as well that are also in parts of the agenda as well around CQC, the corridor care and so our operational pressures, also staff survey results too. So if you have questions here, then there might be an opportunity later on as well. Any questions, comments? No, so that's for us to note. Thanks, Owen. Let's move on then quickly to the review of quality governance. So this is a progress update from Juliet.
Thanks, Chair. I'm taking this read. There's just 2 things I wanted to point out in the paper. Of interest, the work that we've been doing around risk management. That we did set up the operational risk management group. That's now been adapted to work with our new clinical groups, and we've had 2 meetings of the executive-led risk management group. A lot of engagement with that. The reason I'm pointing out is it leads into the work that we're going to do around that, which the audit committee's overseeing. So I just wanted to just point that out. So we've got that going. Owen's chair the two exec-led risk management meetings, and we start to see some better conversations, I think, and better governance around it. Interestingly, we did see the vast majority of risks that we're dealing with when we consolidate it all around digital infrastructure. So we'll be doing a little bit more work on that. That's all. Thank you.
Okay, thank you. Any questions or comments on the quality governance update?
It's very quick, but accuracy, 4.1. I'd like to say that Dr. Eva Khan is also a member of the Finance and Performance Committee, not just Quality Committee.
Thank you for that update. Yeah, it's a helpful consideration to have quality and finance from a clinical lens captured as well. So yeah, really important. Thank you, Jeff. Any other comments or questions? This is a progress update for us. Okay, thank you. So this will continue to be monitored through the assurance committee. So we're being asked to consider if we are assured on progress. We've assured on progress today, thank you. And also that the committee will continue to receive the assurance on the actions. Thanks for the update, Julia. Okay, let's move on then to CQC update. Again, that's over to you, Julia.
Again, just a couple of points that I wanted to show colleagues of. As we moved into the new clinical group structure, we've done a piece of work which mapped all the actions that were currently set against care organisations into those groups. Those groups have been getting to grips with that. They've had quite a bit of support there. So I think that was one of the concerns that I think we might have expressed here, but certainly CQC had about the transition. So that seems to be going well, excuse me, well at the moment. I just particularly want to pick out the Reg 29A. And in there, we've had a meeting with the CQC around progress against there. You'll see that we did have quite a number of actions. A number of them were closed, a number of them we're still working on. And we have got an exec-led monthly assurance group, which will be chaired by me. We're making sure that we're setting the barrier for that assurance test quite high. So we've got some, not only we've got some confidence around sustainability of some of those actions. And so whilst we're at where we want to be with the Reg 29A, I think it's a position that does reflect where we are and some of the significant challenges to meet the requirements of Regulation 29A, notwithstanding for 7-day services and therapy staff, which is so I was going to take any questions.
Okay, thank you. Any questions? I've got Hina and Jeff.
Thank you. I just wanted to pick up on the section 29A, and it says, you know, it's great that we've made progress and 10 of the actions are completed, but there's 30 remaining outstanding. Do we have an indication of time frame for that and what some of the barriers are and how we're mitigating some of that? Just so we have an understanding of when we can expect for those actions to be completed as well.
Yeah. I think we would have liked to have got more actions completed by now. So some of the big things that one of the big pieces of work was the reconfiguration of the surgical bed base at Salford Royal. So what we found at that time of the inspection was we weren't allocating patients to designated wards, therefore the ward staff didn't have all the skills needed to meet the needs of the patients, and also the medical staff were wandering around Salford site. That work's currently underway at the moment. We've had some of the moves, but there's still more moves to take. We've had to do some remedial estates work as well. So what we, on the face of it, seemed like a reasonable thing to do, a quite speedy thing to do actually, when we've got into how we would make that work over a long period of time. We've had to do that work. So we're still on with that, and that's actually then led to the piece of work we're going to do around the whole bed reconfiguration across the organisation. So that's where the learning for that's come. Some of it, access to 7-day services, we've already had the paper on there. Some of those will be a little bit more delayed. So there are some specialties where we're not having those reviews speed that we would, and we had done after. So that's another one. And then the big staffing issues, they're really driven by sickness absence. So we've recruited into all those areas, but we're still struggling. Still got moving quite a lot of staff around on a day-to-day basis in order to maintain and stay staffing. So some of the smaller actions are dealt with, but I was wondering if I'm going to pick 3 things that are actually quite things that you will see throughout various papers of the board. They're some of the ones that are a little bit more challenging. So, you know, with a fair wind, some of this is probably going to still be within 3 to 6 months to get some of these things where we're absolutely sure that they're implemented and sustainably working.
Okay, thanks, Hina. Tim, we have got quiz with us because technical challenges because video, he is going to join us. But is there anything from a quality committee perspective that you want to add in relation? Because obviously this is a overseen there at the quality committee.
No, I think we have pressed on to kind of the areas that Nina has touched upon there.
Can you just put your mic on?
Oh yeah, sorry.
Thank you.
So I think we're content at Quality Committee. Juliet has given us clarity of the standing against the 29A takings and kind of the progress. So there's a good trail there of the board through that committee being cited on the kind of moving parts of that. So I think that was probably 2 quality committees ago we pressed on that. So we are content with that.
Okay, thank you. Jeff, did you have your hand up?
Once we talk, same minute.
Okay. Any other questions or comments? No, so we are asked to ensure that there is oversight, which I think we've been assured of. We've had that talk through in terms of the process, and also use the information contained within the report as a source of insight and triangulation, which I'm sure we'll do throughout the remaining part of the meeting and also in our visits out in the trust as well. So thank you for that. Thanks, Juliet. Okay, let's move on then to the board assurance framework. Oh no, sorry, I missed the IPR round, because it was the big conversation. Okay, let's move on to the IPR. Please. Yeah, thank you.
So as we close, this report is to close the year for 25-26. And in the month of March, whilst we are not in a position where we would want to be in terms of our overall performance, we have seen some of the best performance since the legal existence of the NCA back in October 2021 across RTT, 18 weeks, UBC, 4-hour performance, and our cancer performance as well. So in terms of the confidence that gives to our colleagues in our ability to deliver shouldn't be underestimated, given the challenges that we have got going into the year 26-27, skipping a year. We still have challenges with our longest waiters, 65 weeks and over, and that is multifactorial. However, we are seeking mutual aid to support us in helping to deliver those. We are also seeing special cause improvement on our welcome back compliance, which we've been able to in conversation, and then we're seeing some consistently failing targets, particularly around MRSA, which is presenting us with challenges. That was all I was going to say. People have questions.
Okay, thank you. I think we have got Chris on the call as well now. His camera's switched off, but he is with us as well. So if there's any questions from you, Chris, please do let us know. Or if there's any questions that we may have use the chair of the quality committee, we can come back to you. Any comments or questions, colleagues? Ina.
Thank you, Leah. One of the things that I picked out on the report was the DNA rates that we're experiencing, and I know it's not just to this trust. You know, it's something that national people struggle with. Patient-initiated follow-up. I just wondered how effective are we at utilising that to try and mitigate some of that DNA rates.
Thank you. So we have a number of projects that have gone live, haven't yet been rolled out consistently across the organisation. Invite to Book, we know, is a successful way of reducing our number of patients who DNA, because the onus is on the patient to want to come in and arrange time that's suitable for them. And then with PIFU, we are around the 5%, but we know that we've got more opportunities with some of our bigger specialties.
Okay, thanks, Leah. Jeff?
Thanks, Chair. Just through you, Chair. In fact, it's a bit more about the thoughts on 6 to 5 weeks for referral to treatment. Is one of those targets which I think we're expected to absolutely hit. So you can understand a bit more about how we're going to deal with that deficit. Secondly, in a sort of more general sense, the targets on side 48, 49 relating to cancer and the treatment. Good performance, particularly towards the end of last year, reflected here. Again, just provide a bit about how we terms the targets will raise next year, this year in now, and the subsequent 2 years. So how far the bar is rising, and whether we need to do any more, particularly to advance the board's committee, to assure ourselves we can meet that kind of challenge.
Okay, thank you. Leah, do you want to pick that up?
Yeah, so in terms of 65 weeks, the most significant challenges are in gynecology, complex endometriosis patients, and access to theatres to treat those patients. We're looking at mutual aid across, in the first instance, across Greater Manchester, for access to theatres to be able to support those women in their treatment. And the second most challenging area in 65 weeks is buying, and again that is access to theatres. We know we've seen a reduction in uptake of support for additional sessions in theatres, which we are picking up with actions, myself and Juliet. And then we are also looking at Merseyside in Cheshire in terms of what mutual aid can be provided to support the reduction in our long waiting times for patients. In terms of going forward for 26-27, we know that the 3-year plan is stacked, particularly challenging in 26-27. We are still working through, we have commitment to achieving those standards for UVC, cancer and RTP. We know that they are particularly challenging, and we're still working through with teams in terms of what we can do to address the gap. Some of that will be supported by the 7-day working with the value shift programme that will release some additional capacity to allow us to see and treat more patients. Then we have a number of deflection schemes that we expect to go live, which we said we will keep a close eye on through plan performance committee to make sure that they're also delivering throughout the next 12 months. And then our UEC targets, we have a number of estates programmes which will release some improvements in performance. We are, in terms of our UEC at the moment, we're looking at marginal gains across a number of areas. And again, working with Juliet, because we know that we will improve flow when we've improved our ability to discharge early, and that will come by having our patients cohorted under nurses that are more akin to that group of patients that we're treating, and doctors able to make the decisions.
Thanks, Jeff. Thanks, Leah. Tim?
Thanks. Yeah, just a couple of areas that I see sticking. Sickness first, it's just maybe to explore the strength of evidence. We kind of look at welcome back compliance, certainly through HIT, the IPR, as what is dealing with sickness absence. And it's kind of just, do we need to challenge again the strength of evidence that links that to improving our sickness rates, and whether there should be sort of other measures we're looking at with regard to that. So over quite an extended period, the welcome back compliance is going up, sickness is sticking. So just that one area, and the other one would be the PALs and complaints. Again, what and the resolution of those, that is kind of been in the same place for a long time. And just one meeting I was at last week in maternity, there was kind of a sense the frontline there, they don't get the PALs and complaints until well after that time, so they can't meet the deadline. So I was kind of wondering what different focus we're giving to improving that position. So it's just two areas that I know are kind of fairly intractable, just whether we've got the right measures in the IPR.
Tim, did you got the welcome back question?
Yes. Thank you, Tim. And sickness is absolutely a significant challenge for us. In terms of the evidence around welcome back, improving and assisting, managing and reducing absence, along with early plans for those colleagues who are of long-term absence, there's a wealth of evidence. The Trash Institute Personnel Development, Ipsos Morios, the King's Fund, to name but a few. There's a huge amount there. The issue is it's not an immediate transfer. So whilst we are seeing improvements in the welcome back, this is around a cultural shift of early engagement, early intervention, making amendments and supporting colleagues to ensure that we're avoiding absence. So we're sort of in the phase, if I use the analogy of downriver, taking people out of the river rather than we're moving more towards upriver where people might actually be going off. It's about a cultural shift of support, engagement and oversight, as well as accountability. They are absolutely still the right things. There are a number of measures we see here in the IPR, but that doesn't mean they're the only things that we're doing. I mean, if I talk to the staff resources, we have a really well developed staff resource with mental well-being, physical well-being, financial well-being that supports our colleagues, and that has been developed over a number of years based on the feedback from colleagues from staff side, from the trade unions, from speaking up cases around what our colleagues need and want from us. So my view would be there, that real focus on welcome back and that focus that we've now brought in. So we've started reporting and will do from March onwards, to ensure that there are active management of those colleagues and support for those colleagues who are off long-term sick to reduce their absence. One of the problems with this is, whilst we've seen an improvement in the welcome back compliance, we've seen it predominantly in the summer, winter period. And what we can't tell is the but for, where might it have been had we not got this increased focus on absence, because we do know that our absence is whilst we're slightly higher than our neighbouring organisations, we're not significantly an outlier compared to other organisations, albeit we are one of the highest in GM. So I would say it's still the right focus, but we're not seeing that shift. And as we work through the monthly performance reviews, seeing the trajectory for reducing sickness-related absence, seeing the work around welcome backs, we are hearing a significant drumbeat in terms of an improvement around that.
Okay.
Great. And Juliet, do you want to pick up the Paul's question?
Yes, but I'll just put a comment on the sickness absence as well, if I may, because obviously a lot of this is sitting in nursing. And we just had exactly the same conversation this morning with my senior leadership team about trying to understand why we're not shifting in the way that we could have expected to shift. So we'll continue doing that piece of work. We are seeing some improvements in some areas. We're trying to do a little bit of understanding of what's working in one area. We keep going back to we focus on the right things, is policy right. That's a constant feature, but I do think we are working in an area where we've got higher levels of sickness absence, the workforce that we're putting from as well. So some of the things we're trying to understand is, have we got what's our baseline in some of these areas, and we're going to have to do some adjustment on our staffing models as a result of that, because it's obviously driving a lot of temporary workforce spend, and also a lot of the issues that the CQC picked up in their 29A. So obviously Karen Coverley, one of my deputies, has got a work stream specifically focused on sickness absence, and see some shifts, but not. So we're just going to need to do a bit more work to understand what's making why is it not shifting in some, shifting in others. But I think one of the things certainly is high rates of mental health illness in some of our workforce, and higher burden of caring responsibilities. We're seeing leave for parental leave increasing as well. So there's some there's some shifts going on in there, but there's still a significant lack of availability. So whatever leave you want to tag it to, we've got an unavailability, which is driving a lot.
But we've got a very kind of ambitious reduction target for sickness and the financial sustainability plan. So I guess we've got to confront, is there a route, you know, are we still confident of the route to achieving that? Because all the factors, you know, they are very difficult to deal with, but it's kind of ensuring that we are on track to deliver what our FSP is set to do. So I guess at some point we need to confront that.
Yeah, I just thought what help to add to that is actually Suzanne and I have done quite a lot of work on how we set out the reality of the ask of the FSP, and we've talked about it here before, and the committee's the scheme of delegation letters. So actually putting real understandable numbers around the challenge in terms of our workforce reduction, whether that's around, you know, whole-time equivalent improvement we need to see by area against sickness absence. Once you put it into a really measurable number in terms of individual heads and whole time, it helps with the reality. We've given that number to each of the clinical groups and corporate areas with a request that they reflect and sign up to that by the 14th of May. And what we will see then is the trajectory that each of those areas build in terms of how they achieve that number. And we will work through that as we work through each of the monthly performance meetings with the clinical groups and the corporate teams. So I think there's a much more numerical, tangible method for us to see it and then to be assured about it, so that we're asking people to set out what they can achieve and then work to it with them.
Thanks, Phil.
I suppose just before we move on to the second question, I think it's worth understanding, you know, because I guess one of the questions, it doesn't just apply to sickness, but it's across all of our metrics really, is where are we having that disaggregated discussion about what's really going on, because it's going to be different across the organisation, particularly if it's size. And where are we exploring some of those nuances around, particularly around health inequality? So waiting lists, for example, you know, we're reducing it, but it could be related to a validation rather than people being treated. There could be sections of our community that are not being seen at all, and we're still not addressing that when we look at the global picture. So what are we content that we assure that disaggregation is happening in our governance structures across the organisation, across all our metrics actually? Because when it comes here, we just see high level stuff and it's really difficult to understand how we getting underneath that. So I think it's good to just hear a little bit about that, because I think that's key to the question that Tim's raised, particularly around if we've made assumptions in our financial sustainability plan, at what point are we going to say what we're doing now is not going to achieve that? And some of those are, as you described, Gertie, happening at a very kind of, you know, disaggregated level, which is helpful. Lee, do you want to start with that? I don't know if others want to add.
Yeah, thank you. So obviously we were commissioned to sprint in Q4, and we did see up to 3-4% improvement related to validation. We did also put on an additional 12,000 outpatient appointments for patients to be seen. In terms of where do we have the discussions through our access and performance meetings to ensure that we can look, we're starting to see more of the data come through that tells us around the inequalities. We've certainly been able to see that sometime in cancer, and for our patients that are waiting over 63 days. And is there something else that we need to do to support those patients to come in and be able to be diagnosed and treated? So we're having those conversations in our local access and performance and the NCA one.
Do you want to pick up the first question, do you?
Yeah, so some of the deterioration in performance is because we've closed more down. So obviously we've closed them down, but they've got extended time frames. So there is a little bit of a driver in there. A lot of the, so we're looking at some of the causes of the complaints and PALS as well. So waiting is one of the most significant sources of complaints and PALS. But a few things that were just, they're in the, some of them are in the experience papers a little bit further on, but we're just about to go out to look at how speed the supplier of the personalised TV systems.
Oh, yeah.
As we're going out to the end of that contract, but there are some organisations that provide that facility with real-time patient feedback as well, so we'll be able to get some more real-time patient feedback, which should help to start to deal with some of the health that's coming through. But I think we're doing some in my team, because the complaints and policy sit in my team. We've separated some of those out. We've brought in a new assistant chief nurse working catered office in my director of nursing, so specifically focused on patient experience, and those two teams are starting to work more together. You see a lot within the papers further down about some of the work that we're doing, but there is backlog work going in just to get the numbers up. So we should see them start to go up. We're closing down the backlog, so the data would look like we're closing them down now at times. Closing them down. There are some areas where we still need to do some more focused work, and we've seen the one that kept coming up was maternity, and we've seen some improvements in that as well. So still quite a lot of work going on in that area, and we've focused it with a lot of it on waiting times driving some of the numbers. Just as a little aside, which you might have seen, we're seeing more complaints coming through that are AI generated, much more complex answers, so taking a significant amount of time. There's been something in the press recently about seeing an increase in that. So I think we're going to have to think about some of that. On the flip side of that, there are some organisations that are using AI to support answering the complaints. So there's some, I think there's some shifting in, but we're definitely seeing that some of our complaints coming through 3, 4, 5 pages long, which just take a lot longer to answer.
So the AI responding to AI.
I did say that. I think we can just set the people out with it, but obviously we don't want to do that. But it is so. There's some shifting ways in the way that people are behaving now as well. So so that the numbers don't look great on that, but there is an explanation for that as well. But there's some stuff going on in the background.
Okay, thank you. Thank you.
Do you want to respond
Just
to that?
a follow-up to her complaint, sorry. It was just to clarify that we're assured that we. Oh, sorry. Julia, it was just to clarify, are we assured that the complaints that we are seeing are getting screened at some level initially when they come in, so we're assured the patient safety component is there? I appreciate that obviously the time to respond to it, but what I don't want to think is that we're missing things that we need to act on urgently and quickly from a patient safety perspective, and that's potentially being delayed. So just some assurance around that.
Yeah, I could bring you the numbers of that, but we do get the R screened at outset coming in back, and I can take an action to give you where we are in performance of first response, which is where they're screened in, and I'll get it to.
That'd be great, thank you. Thanks, Tina. So I've got Carmen, and then Joe, and then Suzanne.
Yeah, so I was going to knock my question was about pulse, and I'd like to see what the response was, because looking at the data, I was concerned that it's been below our target for such a long time, and then it's taken a dive. So it looks in the report like we've actually taken our eye off it. And then I was heartened to read in a report later on that we put some dedicated additional support in. But I'm guessing we're not seeing the outcome of that support because it's not showing in the report. And is it a long lead time to get the answer to? Has that made a difference?
It's making it. What isn't in here, I guess, is the number of complaints that we responded to. So the number of complaints responded to within the good negotiated time scales has dropped because we've started to answer more. So now we can gather the data which say what could we have in the response time. So we have put more focus into the team, putting some improvement into the teams as well. There is a high sickness absence rate within these teams as well. And we've separated the teams out to part of it sitting in this and part of it still sitting under duty patient experience. So I am expecting that to start to turn the other way around at the moment. But there's still more work to do to get that team functioning as in the way that we need them to do.
I would appreciate seeing the information talk to Hema about how quickly, what's the performance with that, how quickly we respond in terms of acknowledging rather than including the investigation into the issue, which is still important.
Yeah.
And then, because we've had a conversation about sickness, I just wanted to add, for me, I would like in the People and Education Committee to do a little bit more work on it, not just how well we do with the number of welcome backs, but how effective are they? So it's not just that we've done more of them, but what's the quality of the conversation, and is it making any difference in terms of how cared for our workforce feels, that might then change the numbers that we see, and we get a better outcome, and therefore the impact is positive on our wider teams who might feel that they are carrying colleagues who are absent. So I'd like to see that as in the support of people in education.
Okay, brilliant. Thanks for that. Okay, Joe.
Thanks, Chair. Yeah, what was a very brief reflection that just on this item, the use of the three-letter abbreviation, IPR, RTT, UEC, DNA, and then PFU has been quite frequent. So I think this must be hard for members of the public and guests to follow. So that's a reminder to us all to be included. The point I wanted to raise was on sickness absence, is whether the board feels there's sufficient evidence, communication to all colleagues across the LCA of the nature of the issue, allowing them perhaps to reflect on the responsibility side of the balance of rights and responsibilities. I think the NHS and the evidence we see here, the NCA is very strong on providing support structures and care and empathy. I'm just not sure the degree to which all colleagues in all points are aware of the rates of sickness absence in certain areas, if they'll be able to even posit what the NCA sickness rate is, and more to the point, the consequences of that each day for their colleagues and for the communities. Because I think not being shy about this, transmitting it very transparently, being very careful to avoid and a sense of blame and shame. But just to say this is the picture of what we all do. It shouldn't be confined to a managerial hierarchical structural problem about everyone, what everyone wants to do and can do. But if they can only want to do something, they really understand the nature of it.
Yeah, okay, good point. Yes, do you want to say anything about that? I mean, I suppose that's the question I'm thinking about the application, who sees what, where, and stand a bit more, not just in sickness, but
I couldn't agree with Joe more, and I think that is the conversation we need through, for example, the monthly performance reviews, is that reality conversation about what it means. And if colleagues remember, we had a reflection here recently about some of the work that was being done, and specifically on sickness. We had a really good set of conversations in the People and Education Committee in January, where they specifically looked at what did it mean, their sickness absence rate, in terms of the older theatres, and what it was the equivalent of. And then people did rally around. It is absolutely about those local area managers holding and understanding the numbers and the granularity of it, and having a team conversation around it. You know, Joe, I couldn't agree with you more. There is, you know, this is a two-sided coin. You know, there's support, but there's also our accountability to deliver our contractual elements.
Brilliant, thank you. Chris, welcome. We are just on the IPR, so give you a chance to sell in case there's any questions you've got. And I'm going to come to Suzanne.
Thank you. Is it a benefit or not that when you go last, sort of people say some of the you're going to take on? But your question, Chair, was around where's the discussion taking place and where does the assurance come? And I think what we've heard is there's multiple places that it's taking place, because these are sort of core challenges that our organisation is facing. So, you know, whether it's, you know, from a perspective around how we make sure the access and performance meeting is having that lens around health inequalities in terms of waiting lists, absolutely in our performance reviews, particularly now in clinical groups, to have that dialogue about, you know, where they see with their sort of new set of eyes, where they see hotspots of focus, where we might need to pay more attention, but also where there's positives and learning that can be spread from others. That's given us a sort of good lens, and also would endorse the comments that Joe made earlier. I guess the one that we haven't touched on is the improvement board, and the improvement board, which follows the national oversight framework, the NOP areas, which covers access, quality, people metrics, productivity plans, the whole thing. We acknowledge that health inequalities is not currently contributing to the scoring, but we think that that's important that we do pay attention to that. The national view might be changing on that, and metrics may well come, but that again gives us another opportunity to make sure that we're paying attention to those things and providing a triangulated consideration of some of the matters we discussed today, because they're all critical, whichever one you look through in terms of what we need to achieve.
Yeah, thank you for that. I mean, I think regardless of whether it's included in national oversight framework, we would want to be paying attention to it here in our community in particular. So it's good to see that that's happening. Chris.
What do we do now? Press that. I just on the health inequalities. I think we made this point several times in previous meetings. But there's a moral argument, isn't there? An ethical argument. There's a practical argument. There's actually absolutely a mathematical argument as well. So unless you address health inequalities, you can't address the headline target. I mean, I just think that's a core thing. But without addressing that differences, you don't address the overall. So I think, as well as all those other very compelling arguments, there's a real issue here it's about the overall performance. And what I'm really saying is that I don't think health inequality is different to overall, it's part of an integral to it.
Okay, thank you for that. Thanks, Chris. Well said, as you joined us to pick up that thread as well. There's a couple of things we've not talked about today. One of them is about theatre productivity, and we touched on it in the sense that it's impacting on our overall performance, but we were on a huge improvement approach to theatre productivity, not least with our digital agenda as well. So just wondering if you've got anything to say on that. And then the other is, of course, corridor care, which we've very had a really strong commitment at our board to address it. That we've not really talked about that, eliminating corridor care across the organisation in terms of it being systems. I just wanted a bit of an update on that. And the reason why I'm asking it is obviously great performance at the end of the year in terms of the best that we've ever been, but we can't relent for 1 second, can we, in what is probably going to be the most difficult year in terms of, say, finance and outcomes for patients in terms of what we need to achieve and the mountain that we need to climb. So I think we need to think about a way of how we make sure that while we're still looking backwards, we've got a real up-to-date position, and those things that we are focusing on are still delivering the right things in terms of outcomes. And if we need to switch, we quickly and agilely, that's the word, so quickly and able to switch to another action that's going to resolve the challenges that we're dealing with. And that's why those assurance mechanisms are really critical to do that and use data in an effective way. So Leah, any thoughts on those?
Thank you, Chair. Suzanne and I had that very conversation this week about how we manage the medium-term plan, and that we will need to respond monthly in terms of the direction, sometimes changing direction if we see ourselves going off course quickly. In terms of theatres, Suzanne is now the SRO for theatres. I'm not a hospital pass in there. We have the programme is established. There has definitely been some challenges with theatres. We've completed the second session of the 3 Rs for theatres here at Salford, and we have some improvement programmes coming online, which will be part of the wider NTA theatre improvement programme, and the theatre scheduling system is due to go live on the 2nd of June. There has been some delays with that. The latest update is that is largely broadly on track to commence on the 2nd of June, which will enable us to use data better and to schedule into theatres. Don't know if you want to say anything else in theatres before you corridor care.
Yeah, just to say actually, because it's, you know, we've talked a lot about our clinically led model as we developed it over a huge period of time. So for me to now be involved in the theatres work, what is incredibly encouraging is with our new clinical leaders and a fresh set of eyes and a renewed energy around how do we really focus on the key pieces of work within theatres to be able to improve where our voice, not just for you know, where we might stand nationally, but the whole point around treating our patients in a timely fashion with great outcomes, which is what we've heard from our theatre colleagues earlier today. So they're meeting today, right now, as we speak, under the leadership of Joe Humphries, who's our Managing Director of our Families Anaesthetics Critical Care and Theatres Group, ACT. And again, with that sort of renewed energy of both of the really targeting 3 key areas around productivity, which will be reducing our number of cancellations, improving utilisation through theatres across the Northern Care Alliance, around non-pay, which is to make sure that, again, best practice that we use from a procurement perspective in some areas is rolled out across, and we're really focusing on low kids, as an example, as a key opportunity, and then workforce, which links us to, again, some discussions we've had before earlier. So I think they're very clear. They've got some real energy behind that, and we're going to start seeing some of that progress into change portfolio board and straight to board as well.
Brilliant, thank you for that. It's helpful. Bobby, I'm going to invite you in to share a little bit about it.
Yeah, I think just on the theme of what Suzanne's talked about, I think last week was the 5th session in relation to get it right first time, and particularly in relation to Salford theatres. We had the new clinical leadership that now sits leading that conversation. So there were a number of colleagues I got met before, and we had an introduction and a description from those clinical colleagues, and not just medics, nursing colleagues as well, and describing what the work was, that's in sort of 3 hours terms. And I have to say, my breath was taken away about the clarity about what they were doing, clarity on the trajectory they wanted to reach, and also the clarity of the asks that they were making of me and other colleagues in terms of resources and states and facilities and so on and so forth. So you have a question about where are we seeing that some of the more granular understanding. I think part of what Suzanne was articulating, the improvement board, but also in terms of what she's describing, there's multiple points where we're seeing some of that. But I'd also added there that the get it right first time approach, and also having the national input to that in terms of our standard setting and what good practice is. We've really seen a difference coupled together with that new clinical leadership. I think there's real opportunities for us to take advantage of, Chair.
Thanks, Ellen. Okay, Julia.
I was just going to do the corridor care one. I don't really want to open it up and I'll contribute.
Okay, so in terms of corridor care, we did see a reduction in March, moving that into April, the movement of election in April as well with our resident doctor colleagues. We're continuing to see that reduction. However, that's very much around grip and control, and really setting the standards, the basic standards. That we won't tolerate corridor care, that we want our care to be in the right place, but that needs to be underpinned by improved flow, which kind of segues into the improvement work that Juliet is leading.
Yeah. So alongside the work that Suzanne's doing on it is also leading on a piece of work around length of stay, and we know the key drivers of congestion and related to the distance flow out of ED is related to our long lengths of stay in our specialty areas. So they're meeting today as well, chaired by with the SRO, Catherine McMahon, who's very, very enthusiastic about this. Building on some work that had already been going on, which is Safe Sooner programme, which has been led by one of the colleagues in Leah's team, which is focused on flow discharge and some of our very high use acute specialties. Also picking up a piece of work Karen Covell is leading on bed reconfiguration across the whole of the NCA, working alongside the programme of work we're doing around RAC, and then also focus on hospital homes and how we make better utilisation of facilities outside of hospitals. So hoping that with kind of the grip and control that we're talking about getting flow, that we need to focus that. I think we've definitely seen certainly in our daily UEC standard calls, see the much more greater focus on discharge and length of stay, but I think getting the bed reconfiguration, so we're getting the patients to the right place, we're getting good decision making. I think they're all pieces of work that are contributing. So some of these are quicker fixes that we can control with it, but some of the other stuff is a little bit of some of it will have some impact in the next 2 or 3 months, and darker lists, some of it's going to take a little bit more time. We're working with Lorna's team around what the module would look like, kind of to manage logistics better around patient flow and utilisation of this. So there's kind of a mix of kind of short, medium and long term pieces of work around the corridor care in its widest sense, because there's still have some traditional, there are some escalation areas open.
Okay, brilliant, thank you. Jeff?
Yeah, just on corridor care, when we last spoke about this as a board, your national meeting, we were told that there is work ongoing on definition and how also reported, sort of an update on that when will we get clear performance data?
Do you want to pick it up, Leah?
Yeah. So we know that there's a first draft of what that performance looks like based on the new standards. We've been asked to validate that position and ensure that it will be a daily condition that goes out based on the new definitions. And once we've started to see that and understand it, we can pass that into performance reports so that we can see more clearly how we're performing against that standard.
So not yet.
Not yet, but it's part of the next board. Certainly the board.
Okay, and we can certainly pick it up at quality between Alvin. Okay, Chris?
Just to echo something that Julianne said, I had the chance to talk to Catherine McMahon yesterday, and I suppose it was so heartening to hear a senior clinician talking about these issues in some depth, actually, saying enthusiasm, but I think a degree of knowledge about them as well, which at least gives some credibility to the things which are going on. So I just wanted to echo that, Julian.
Brilliant, thank you for that, Chris. Okay, any other comments or questions, Leah?
Just partly because I was feeling left out because we talked about the other two improvement programmes. There's also the application improvement programme that is meeting today as well, and that's chaired by Graham Nelson, who is one of our newly appointed elective recovery consultants and elitist by background, so asking some very different questions of our outpatient colleagues, which is positive, and we are looking at implementing the GIRFT follow-up standards, because all of what we see is really a congestion of us bringing in patients that perhaps we don't need to, either through different deflection methods if they are new patients where they can be treated sooner and in alternative locations, or for our follow-up patients who really, back to the questions from Hina around DNAs, where people don't see value in their outpatient appointments because there's clinically no value to them either. So we're implementing the GIRFT standards across those as well.
Brilliant. Thank you for that, please. And I think that's a really good conversation. And what I'm really heartened by is how we've been able to map the new structure with our clinical leaders into the improvement priorities really quickly, which is absolutely what we were worried about. But it sounds like that's been really strengthened and has brought with it a sense of urgency and enthusiasm that is focusing on those key priorities. So really encouraging to hear that really strongly today. So thank you for that. So colleagues, we are importantly, I think, on this recommendation, being asked to receive the report, integrate performance report, but along with all the other assurance and improvement actions that we see through the board committees reports as well. And I think that's what I was trying to encourage today, is that we wrap all of those things together in the conversation about the integrated performance report. So we don't have to do it again a second time when we get to the assurance committee, but also because we should be in that kind of rounded approach that we look at it, because obviously they all impact on one another in terms of our outcomes for our population. So we're happy to agree with that recommendation. Okay. Thank you. I'm going to move on to item 12 now then, which is the board assurance framework proposing position. Tim.
Great, thanks, Chair. So by and large, I've asked colleagues to take the report read for 2 or 3 key points. First is to acknowledge that we do carry a high risk profile across the organisation. Welcome, no surprise to colleagues, given discussions today and through the course of 25-26. Probably to know that board assurance framework gets significant scrutiny for each of the subcommittees. I've referenced Finance and Performance Committee the week before last as a case in point where the assurance framework took up a significant amount of the agenda as colleagues worked through where we thought where we might want to be. Third point is to note that work is now underway to construct the opening risk position for 26-27. Whilst that will land in July, which probably feels slightly late, it is working through board committees in May and June. And as part of that, we're just looking to refresh the template that we use just to make it more digestible and engaging. I think a number of colleagues have seen that either through change portfolio board or through individual discussions that people may have had with Shannon Fearon in my team who's leading the work. So colleagues, just be assured that the board assurance framework does get a significant degree of scrutiny across the organisation, including now through executive oversight group, which Juliet alluded to, I think, at item 4.
Okay, thank you, colleagues. Any questions or comments? Yeah.
Actually, just if we want the board assurance framework to shape work of the committees, my own view is that we need the revised risks to be articulated for the 1st of April. So we start the year in that mode. Where we are at the moment, we'll get there sort of June, July time. So for me, this is part of a wider challenge of bringing our financial performance planning process forward in the year, so that we are not sounding national processes, clear ourselves what we're trying to do, how we're going to do this before the year starts. The second point is that you look at the appendix, some of the risks this year not being assured, because the process around which these risks are going to be managed are not being semi-independently assured by business. I think again, I would have always been helpful to have that process completed for all business, and again before the start of the year, if possible, near to the start of the year. Maybe capacity issues around that, but ideally, I think that's what would help us make sure we start the year knowing with everything in place, just dedication tracking of are we delivering on it.
Okay, Tim?
Yeah, I think I'll take the last one first. I think through audit and risk committee, I know the chair of that, Tim Crowley, has asked that we agree what that schedule looks like. We just need to be cognizant that whilst we want Louise and her team to assure all aspects of the organisation, whether that's the National Oversight Improvement Framework, whether it's through change portfolio or whether it's back, we need to be cognizant of capacity requirements. So we're working through what that will look like on an Oaktree Financial Performance Committee. I think Jeff, you requested that collective care, I think one of them that we wanted to bring forward for assurance in 26-27. With regards to the opening position, I think the move to a multi-year board assurance framework will enable us to get to a starting position for 27-28 far early, because we will be ostensibly carrying risks through, as opposed to historically where we have closed the position and then reopened it immediately with some real anomalies around some of our financial risks. As an example, just need to be confident that the historic reason for doing an annualised risk profile is because we worked on an annual planning cycle. It's really with the advent of a multi-year planning cycle that enables us to move into the space.
Okay, thanks for that. Any other questions, Chris?
Tim, fairly, that's just a slightly technical question, but what you just said in terms of multi-years, what does that do for things like risk appetite and risk tolerance? Because I think they'd be different, wouldn't they, per year as opposed to multi-year. Do we need to have that discussion at some point again?
Yes, we do. I think risk appetite, risk tolerance is a conversation that Tim and I have picked up. I'm hoping to do something with board, subject to diary commitments at some point towards the end of May into June, recognising that the GGR report in particular sort of queried our risk appetite and whether we were unduly optimistic. I think the introduction of tolerance was probably the right step, but again, as a collective discussion required us to, is it as value adding as we think it might be, particularly given that 26-27 we'll probably see 2 target scores added to the board assurance framework, 1 in year and 1 multi-year, which gives a different dimension to assess whether we're effectively managing the risk or not.
Okay, thank you. Any other comments or questions? No, so there's 2 recommendations, one to receive the closing position for 25-26 for the board assurance framework, and the other is to acknowledge and support the work being undertaken to develop the assurance framework for 26-27 and beyond. Sounds like as well. We're happy to do that. Okay, thank you. Let's move on then to change portfolio board 13.
Thank you, Chair. And again, in the spirit of the Halloween meeting, I'm going to assume that the report has been read. Also point out that we had a couple of non-executive directors in the conversation on the 20th of April. I'm happy to take any questions or comments, and obviously Louise is going to follow the assurance piece there.
Okay, thank you. Any other comments or questions on the AAA report, which is in the pack for sure? Jeff?
Raise an issue about the scope of the change portfolio board. So I know it's under review, but what is excluded from change portfolio board are the changes needed to deliver on our constitutional standards. So they all go through the National Outcomes Framework approval, which was mentioned earlier today. I know work is going on to look at the governance of the approval. I wonder whether we can have an update on when that will come to fruition, because it seems to me that enter the change portfolio approval doesn't yet have the same ability to direct program and project resources. Doesn't have the same visibility at this point, and it doesn't have the same, I believe, application of the assurance process that again the users team provide for the change proposal. I'm just trying to make sure we raise the ability of the organisation to deal with constitutional standards to the same level as these important changes through the change proposal.
Do you want to pick up? Sorry.
Yeah, so just in terms of the, so there's a couple of things. I think it's been articulated to you, Jeff, that the process of assurance that sits within the NOC Improvement Board is being developed. And we've had various situations, and Louise may be able to talk to that. And also we've got lads and Nicola who's been doing work around that. I think some of that has already been tested against some of the chairs of the various committees, because we've been talking about, for example, what might AAAs look like from the improvement board, and we've got still some work to do on that, because actually the nature of the business is slightly different from what we do in the change portfolio board. The other thing I'd say about the NOC improvement board is that sitting beneath it, of course, are several other groups of governance, for example. And so some of the planning and performance group, for example, that sits underneath that. So I think there is something about trying to make sure that all members of the board understand where some of the work is taking place. It sits below certainly what we do every fortnight in the NOC improvement board. There is quite a lot of input, and that's where decisions about resource allocation and work do take place. And if there's a question, therefore, about the visibility of that and it not being visible to this board, I would argue that as we do the assurance work, and as we get to a place whereby you as chairs, we as the improvement board feel comfortable that we've got a mechanism that can be brought up to the various committees, and you can sit there and say, yeah, I get this alert, it makes sense to me. That's the bit of work that we are working on at this moment in time. We are also, and I think Suzanne touched on it a little bit, in that we are cognizant that the NOF framework, so the National Oversight Framework, and the what you might call the 6 areas, and then the sub-measures that sit within those 6 areas, we're aware of that there is consultation as we speak about changing some of that. And some of that change may actually happen within the year 26-27. So we're doing an act at the moment whereby we're trying to ask the question that says, are the measures and the areas that we're focused on the right areas? So that we've had already about, for example, sickness absence, and we're testing those, and there are some where we're making a judgment that says, yes, we'll stick with those. And there's somewhere we're saying, actually, no, we think now we need to be thinking about other things. These are live conversations that are happening, and we're looking to get to a point on that quite soon. But again, we've just got this little caveat that says it might be that in year there is a national requirement to change some of what we are asked to focus on at this moment in time. What I'm trying to reflect there is actually it's quite tricky navigating this at this moment in time. But I am confident is what sits below the improvement board is an architecture that is led by several colleagues that sit within here, has an interface with the clinically led group, clinical colleagues as well, and should be providing us those questions that says, well, actually, if we don't think we're doing well on X indicator and we need to move resources to support, that's where those conversations should be taking place. What we're dealing with the improvement board is the aggregate level. And as I said, I think it won't be probably too many meetings before we're starting to have the same level of confidence about the assurance that we're bringing to the improvement board as we do and can be change portfolio board at this moment in time. But remember, you're talking about one thing here that has had maybe 2.5 years worth of getting to maturity, and you've got something that is talking that's had maybe 6 months of maturity at this moment in time. So I don't carry anxiety that we will ultimately get to where we need to be. I think there was a thing about recognising that there is a difference, because the change portfolio is about where our fundamental change is taking place. To some degree, the National Oversight Framework is the kind of even better if it's the kind of improved tactical capability of a lot of what we do our normal routine work. There is a distinction, and I would really encourage us to make sure we don't try and conflate those two at this moment in time. Long answer.
So I guess, is there a timescale for that coming back then in terms of that clarity around those? Is it because you're right, change portfolio board's been in existence for a while and it's well developed in terms of, I'd probably argue that the constitutional standards are equally as important as those priorities are in the change portfolio board, their impact our population very acutely, don't they? We know that. And we've obviously signed up to addressing some of those things in a right care in the right place. So I suppose it's just, and we can pick this up as an action outside of the answer there, but it's good to just understand when's that, when we're going to see what that looks like in terms of those assurances that you were asking for.
Yeah, happy to pick that up as an action plan.
Okay, thank you. Chris?
Thanks, Joan. I had the chance of attending the change portfolio board for the first time, and I have to say it's a very impressive setup. As you referred to the maturity of it. I've made 1 or 2 comments on the terms of reference to Louise because I think they've been recognised anyway. So, but the point I just wanted to, and actually Louise has sort of schooled me in this anyway, but I just wanted to raise the fact that in the alerts, when you read the alerts, the 3 alerts, each one of them refers to the FSP, and I think you could read it that we were off track with our CIP on that, on what's written there. I don't think that's the case, but I just think it'd be worth clarifying that for us. Don't know if that's you, Mayor, or Susan.
Susan?
Yeah, so in terms of the target,
Oh my gosh, just with other acronyms.
so in terms of the targets that we set around cost improvement, we've set a trajectory of identification of 50% of our target by the end of March, 75% of our target by the end of May, and 100% of our target by the end of June. We're currently in the middle of that, and we've identified over that 50% threshold. So we're meeting the requirements of cost improvement identification that we've set out. What this is flagging in terms of delivery, because what will be required is month by month, we'll have to move that from identification into delivery, into transaction. And there's a whole process, as you know, that takes us through that, including quality impact assessment, for example. So, so we are meeting those targets that we've set, but we recognise that to keep on track with delivery on a monthly basis, we need to pay attention to both of those aspects as well, because these are critical programmes in delivering the MSP.
Might just be that we need to be precise with the wording for people like me who don't necessarily understand the implications of something. It does give me an impression. But thank you for the explanation, Susan.
I guess the clarification is the impact on the financial sustainability fund, not just the cost improvement programme. And that's the distinction that gives some better clarity in terms of the update. Yeah. Okay. Good question. Joe?
Yeah, just thanks, Chair. Very briefly, I think it's really important to recognise that the art as well as the science of the assurance framework is about leading indicators. So what we're looking for is telltale signs that there may be risk of non-delivery. That may well be rated red. That cannot predict that the delivery won't happen. It's just the strongest indicator that we should be looking at, and a warning sign doesn't mean someone's not going to pull a rabbit out of that, and it will turn green in a month's time, because that future can't be predicted. So it's very heavily geared in that way, and that's the value of it. Whereas in other cost improvement programs that I've witnessed, people sit focusing on the spreadsheets, the actuality, have no sense of what might happen in the future because they're not checking on the fundamental principles. And then just a brief word on the change portfolio board improvement is that I think they're, to reinforce the point, quite rightly separated, because change portfolio board is that it says concentrates on major change programs, and that's the type of business that does well to be isolated and recognized as a portfolio of large change programs, whereas a lot of the national oversight framework work is incremental improvement in core business gaps or failings or underlying trend, and that tends to be much more incremental operational work generally. Doesn't mean to say something won't jump out of them off, if I can use that, and need a change program, which might then merit being in the change portfolio board. But at the moment, I think they're well served to be recognised and managed.
Okay, thanks for that, Joe. Tim?
Yeah, of the programmes, I just wanted to check a portfolio board's confidence with regard to medical workforce? Because kind of when I looked at that, I appreciate it may well have been challenged, but kind of had even the team not in place, resources not identified, engagement plan delays, communication that would happen soon. It kind of putting all those phrases together, it left me not seeing the route out of that. So I guess it's for the SRO and the board itself, portfolio board, the degree to which that is challenged and your confidence in covering that position. Just led me to worry about capacity within that particular programme.
Okay, thanks, Tim. You know.
Yes, capacity had been a concern. We are in some detailed discussions about what the capacity will look like, supported by Suzanne and others, and we're confident that we will have the capacity to ensure that we.
By when, I guess, Rafiq, I suppose it's a sense of quite a timeline to building that capacity, whether that timeline matches kind of the ambition of this programme.
So some of the capacity is about realigning what we have, which was essentially just held back by the fact that we had a significant organizational change. Now that that's settled, we're doing the realignment now, and some of it is additional capacity that we want to identify. That's the longer period of time.
Okay, good, thank you.
We can pick up an action, we can note an action to come up with a timeline. I think the other thing that's probably worth adding into that, I think, is obviously the work that's happening as a result of GGI as well, isn't it? The engagement work with our medical workforce too, which I think is an important element of that, that's referenced in the alert. And there is work underway in relation to making progress. Okay, Suzanne?
Thank you. Yeah, just to build on what Rafiq's described, and to, I guess, to remind the board that back in December time, we engaged some additional capacity and capability through PwC to help put some infrastructure behind some of these pieces of work. We also did some realignment and consolidation work with the improvement team under the leadership of Nicola Bailey. Two examples of how we're trying to make sure that we've got the right support and understanding of what the programmes need to go forward. But this piece is referring to how do we shore that up with Nicola's team now in place, the learning and then, I guess, the expediting that work that we got for PwC so that we can take that forward confidently as an organisation. And the timing of that is sort of falling out here. We needed to be clear about what we needed to support the infrastructure, the pieces of work that sit behind it, the expertise that we need to drive that forward. And we need to make sure that's now in place to deliver.
Thank you.
Okay, thank you, colleagues. We've been asked to acknowledge the update report for the change of portfolio board, which we have to do that. Thank you. And then we've got request any actions from senior responsible owners as required. I think there's three things that we've picked up today. One is the clarity around the timescale for the improvement board, mechanisms to come back to the board, and the second is the update in terms of the timeline for medical workforce assurances, and then the third was around that qualitative assessment that needs to come back in the advisor assure piece around making sure that we're not just focused on improvement, but it's about financial sustainability. Everybody okay with that? Okay, perfect, thank you. Change portfolio assurance report, Louise, anything to add to the page?
So I'll take the paper as read, so I won't take us through the details today, but just to draw out one point, that's just to highlight that the assurance of the governance and delivery of the financial sustainability programmes within the portfolio, the assurance that reflects the 2026-27 financial sustainability plan, and I guess the early stage of those programmes, particularly at the time of this particular report. And then, as usual, any programmes with red flag ratings were highlighted in the matters to alert section of the summary report.
Okay, thank you. Any questions or comments? The assurance report? No? Again, thank you for all of your work on this, Louise. And it looks straightforward, but there's a lot of work that goes into producing the report, so thank you. So we've been asked to receive the assurance report and the current assurance status of all the 11 programmes. We have to do that. Yeah. And then to support the approach to programme assurance of the change portfolio in accordance with the framework. We have to do that. Yeah. And then any action from senior responsible owners. I've not heard anything further than the ones that we discussed previously.
Yeah, we've done three.
Yeah, so thank you. Okay, colleagues, we're due for a break now. We're a little bit ahead of time, but I'm going to take that. So we'll take a break now. I think we were planning to have a 15-minute break, so if we can be back for 5 to. That'd be okay. So, I'm sure. Perfect, thank you. Item 14, which is the finance performance report. So, Jeff's going to just take some key highlights from the March and April finance performance. Jeff.
Thanks, Joe. The performance of both pieces are very clear. So the March meeting was simply highlight the committee had a really good conversation with colleagues from PwC to get assurance that their methodology for search reviews will be effective. I bring that up because the theme of assurance was carried through to the 6th of May meeting, which was dominated by our discussions about how we get assurance on the deliverability of the financial statements and plans on the agenda later on, as you know. And it's very clear before that's up, after the survey, can we gain assurance that is deliverable? Certainly, as you look at the end of last year, we saw a strong performance financially. We ended with a small surplus. And performance, thanks to the additional funding for the security work, we saw performance tick up, not quite to national targets, but nevertheless a substantial improvement. And we should record our thanks to the operational teams who delivered that improved performance on the sprint. Fantastic work. But both on finance and performance, as we said already, bar line goes up. Financially, it must be harder as we have taken what is far some low-hanging fruit in previous years. So we were concerned with the committee to seek that assurance on the plan. We are going to take delivery at our next meeting of the first version of a dashboard of key performance indicators on finance performance, workforce, and bringing for that performance parts together to focus on productivity. That dashboard, I think, will be a key product for, I would suggest, the board as well as the committee. We're also possibly being subject to scrutiny by NHS England. They are also seeking the same assurance on methodology. And we've had a letter from the Regional Director of Finance on that plan. For example, she is asking that our cost improvement program be fully identified by the end of March. Not there yet, and that will be picked up in performance operation performance outcomes meetings with the ICB, where the regional represented. So we're on that in terms of. So there's the key words towards the bring out, Chair, when you answer any questions.
Okay, thank you, Jeff. Any questions or comments on finance and performance committee? No? Okay, thank you. That's for us to note. We've also got item 14.2, which is the 12 finance report. Suzanne, I know this was discussed at Finance and Performance Committee. Is there anything to add?
No, I'll take the report as read and Chair of Finance wanted to put the key bits in it, and when I would have raised it's just it's pleasing that we entered the financial year in the position that we did. As board will know, back in September we took some decisions to and some recovery actions, all of which is enabled to deliver that financial position that Chair and Committee has alluded to. That meant by delivering that financial performance we qualified for a share of the redistributed deficit support, which is enabled to host a small surplus. So I just want to say thanks to everybody in the organisation that contributed towards those results.
Okay, thank you for that, Susanna. And sorry, I did mean to acknowledge the thanks that Jeff had mentioned, because I think it is worth celebrating in terms of our achievement at the end of the financial year, both in terms of our financial outcome, but also in the performance figures as well. And it is, I do want to comment what I've done to the team, so that it's been a phenomenal effort. Sprinting towards the end. Challenge we've got is ensuring the sprint becomes business as usual, but it's a huge achievement, and I think we should play for record and the board colleagues for that. So let's know that. Okay, thank you. And item 14.3 is the mid-year green plan update. So again, I know this has been finance performance for some detailed scrutiny, so don't tend to go through that in detail, but if there's anything you want to add, Susanna, or any questions that colleagues have got.
No, I wasn't going to present that. I know there's quite a lot of materials in there. I wanted to make sure there's absolute transparency at the board. It's one of our requirements from a contractual perspective, not only to have a green plan endorsed, but to maintaining the performance against it. I've alluded to performance, and the Finance and Performance Committee has received these reports on 2 occasions, one to receive the detail of what's taken place in 24 and 25, and since we agreed to plan in July, we'd also received the independent assurance report that was accepted by the Greater Manchester team. So we've had the opportunity to go through that, but the transparency was to make sure all that was visible to the board of directors. The only thing that I did just want to touch on is that we've just appointed a new head of sustainability who will be joining us in summertime, and they will allow us to accelerate even further some of the plans that we've got.
Brilliant. Thank you for that. Okay, Tim.
Yeah, just, I mean, we did see the version of this at Finance and Performance, and it's good to see the progress against actions. Just one that kind of popped up was, I think Jeff had raised the wider point. I seem to have a growing dependency on oil, and kind of it made me trigger kind of that we've got something where we're going to be looking at our vulnerabilities to kind of global risks. So we talk about risks hitting us, you know, but that particular one, I didn't know what had triggered our use of oil from 2022 to 23. It'd be a bit unfair to ask now our oil usage, but it did seem with current sort of pressures an interesting one, and one where we should be looking at our exposure to these sorts of risks for all our procurement.
So oil usage, Susanna.
I wasn't planning on detailed response still, but what we did agree at Finance and Performance Committee is to get a briefing note from the Head of Procurement, Joe Lever, on the global events and how they are impacting on inflation. So I will make sure that oil is specifically included in that briefing for us.
Yeah, because I've read somewhere that the NHS is particularly vulnerable to kind of some of these
all energy
shocks. Yeah.
All energy aspects will, you know, we've made good progress in this report, particularly around water usage. We've stabilised against electric and gas, but I'll make sure that, you know, our utilities are picked up in that briefing from Jolie.
Thank you. Hina?
Thank you. I actually also picked up on the oil thing. It does stand out as we've had 0, 0, 0, and then it shoots up. So that's great. The other thing I just wanted to pick up on the green plan was, we know that inhalers are a significant carbon footprint, and you know we have nationally made a commitment to try and reduce inhaler usage and move towards some of the more carbon-friendly ones. I noticed that the position for our organisation, we're not quite where we want to be. We're at 21%, target 75%, and I just wondered whether there was going to be some work done to try and speed that along and push that along? Because it's been part of the agenda now for a number of years. It isn't something that's just come up, very new. So I just wondered what kind of time frame we were looking at to try and move that and shift that with a view to it's really easy with green agenda for it to get overlooked by the finances and the quality. And actually we need to just make sure that stays at the forefront as well when we're doing our bit as well around supporting the work that we need to do around. Thank you.
I'll pick that directly up. It's opportune that our oversight with the board that I chair is meeting on Friday. So I can pick that straight up into those conversations. We've just got some, under our clinical led model, it has given us an opportunity to sort of re-engage a different group of colleagues as well. So I'm really keen that we get those clinical inputs. I met with a member of Leah's team yesterday with the same conversation about how do we better connect in some of those clinical parts of work that will contribute to our game plan, rather than it's just about the energy and the all aspects of it. So I'll take that away, and pick it up on Friday. Thank you.
Great, thank you. Any other comments or questions on the green plan? So that's to see for our assurance and progress against the plan, which the finance committee will continue to track. Okay, let's move on to item 14.4, which is the financial sustainability plan. Suzanne.
Thank you, Chair. So I'm presenting this document here for approval. I won't go through the whole of it. I think we've had some good conversations earlier in the board actually that sort of triangulate with the point of this document, and that we made a deliberate decision that our financial sustainability plan needed to be more than just cost improvement. And I'm hoping that this document sort of captures that in terms of the approach that we're trying to take. So we have had some good success in terms of cost improvement over the past few years, particularly around things such as agency. And, we remain really low in terms of our agency uses compared to other organisations. But as we move to this next phase, we absolutely need to broaden that. So again, this plan is intended to frame that around a clinical led model. We're taking a much broader board review in terms of system led approach and working with our partners in terms of delivering some of the aspects of this programme of work. The clinically led element is critical. Again, we touched on GERD earlier in the meeting about how that drives forward some of the systemic changes that we need to make. And for colleagues later on in our agenda in part 2, we'll be talking a little bit more about the master planning work that we're doing around RAC, for example. And just going to get Nathan to explain that now, which is reinforced autoclaved aerated concrete. But it's a really important piece of work that's going to drive some of the sustainability questions that we as a board will be asking in the organisation. So again, we tried to broaden it and make sure it encompasses all aspects of work that we're doing. I just want to thank the board as well, because this document has been a long time in the making. We started this piece of work in June, and we've done a heck of a lot of engagement and discussion, and the contributions from board members has really helped us shape it into a document that I'm hoping we can approve today.
Thank you for that. Any questions on the financial sustainability? As you said, we have lots of references to it today already, and it's obviously already due to finance and performance as well. We've got further discussions in terms of delivery, and that will continue to be guided by the financial sustainability plan. Any questions on that? Okay, so we have been asked to approve this plan as the trust formal route to achieving its recurrent financial balance and supporting the delivery framework, including our accountability, productivity and improvement programmes and the medium-term plan trajectory. Have to do that? Yeah, okay. Thank you very much, Holly. Okay, let's move on then to people and education. So we've got a report from the People and Education Committee on the 18th of March. Are you doing that, Colin?
I wasn't at the meeting, but as the chair going forward, I've been asked to do this today. So I'll take it that the report's been read, and we've already had a conversation today about sickness absence, so that will stay as a feature. There've been some good things achieved, which you can see under the green section. And I wasn't going to say any more than that unless anyone who's on the committee wants to add anything.
Anybody else got any additional? Suzanne, you?
Oh, sorry, that's right.
Like to see what,
Sorry, I
okay.
can put mine on.
Okay. Any other comments or questions on people in education? No, so that's for us to note. Thank you, and thank you to Aziz for chairing that meeting. He's not with us as a non-executive director. It finished at the end of March, so I thank Aziz for his contribution to particularly the portfolio people in education. Okay. So we've got a couple of items then that have been to the People in Education Committee, but I think it's worthy of a discussion here at the board. Freedom to speak up annual report, but we'll wait until Shabana arrives. She's not here yet, we're running a bit ahead of time, so we'll give Shabana an opportunity to, we'll pick up when she arrives. And we have the National Satisfaction Survey report, which has already been to People in Education, has actually been to the board as well. So it's not the first time that we've had a conversation about this, but it is the first time we've been able to talk about it in a public domain. So Gertie, over to you.
Yeah, thank you, Chair. And just to reiterate what the Chair has mentioned for the members of the public, we have discussed the National Staff Survey results initially in January and then again in March, which was before the national embargo. So we have, as a unitary board, spent quite a lot of time working through this. I will pull out some key headlines and generally take the report as read. So in here we had a 47.6% response rate. It was slightly lower than we had aimed. We set a really high ambition for ourselves, but I don't think we should take away from the fact that that is 9,800 colleagues approximately who gave us their position, their views, their opinions, their feedback about their experience coming to work here at Northern Carolines. So it's a really strong confidence in the data, with 50% broadly fill rate and nearly 10,000 colleagues. Overall, the position is mixed but broadly stable. 56 measures have improved, 37 have declined, and remain mid-range nationally. In terms of lots of improving, we are seeing progress in respect of team behaviours, appraisal completion, and reflecting positive movement and the leadership in its style and day-to-day culture. The areas we need to focus on are overseeing declines in advocacy, career development, and confidence that concerns will be addressed. And Shabana, of course, will touch on that as she comes through with the Speaking Up report later. So these are some of the key drivers in terms of engagement, colleague experience, morale, and retention. We've talked about engagement, particularly advocacy. We see variation across services in terms of persistent inequalities for some groups. And if board colleagues remember, we reflected on this quite particularly at the last board in March when Jess joined us to talk through our workforce race equality and the workforce disability equality surveys. We have a really clear plan for 2026 built around the 5 improvement areas, which are the same areas we focused on last year, recognising that cultural shifts take some time for us to impact on, and they are aligned to the National People Promise. So real focus on colleague voice, on inclusion, visible leadership and visible action with support by stronger governance. And particular note, Tim and his team have really supported us in improving that flow from board toward through the People in Education Committee to improve governance. In closing, it is a stable but mixed position. We have clear priorities and a focused plan, and the board can take assurance that we are listening to colleagues and we are acting on that feedback and doing that in a structured way. One of the key things for us as we move forward, and the communications team and Julie and her team have been really helpful on this, is that we really have a regular drumbeat in terms of you told us this in the staff survey and here's what's happening to it. And as we share its development innovations to connecting it back to feedback from the staff survey. So I would ask that the board note the findings, take assurance in our response and support the continued focus on engagement and culture. We will bring more regular updates on this through the People in Education Committee, and the board will receive AAAs on that. I would leave it at that, Chair. We're very happy to take any questions or comments.
Great, thank you, Gertie. Any questions or comments? Accepting that we've seen this already before on many occasions, and I think we're clear on the actions that we're taking in relation to the staff survey. This is really important information for us in terms of insight. It's a point in time, but it's really important that when colleagues talk to us about what's important to them, we respond in an appropriate way. And that's what we've been trying to do in terms of sharing the data more widely with colleagues so that they can look at it in relation to their own particular areas. And I know we've been doing some work to remap some of the data in relation to the new clinical service groups as well, so that leaders there have got access to that data to be able to see what's happening in their own units as well. So that's been helpful. No comments? So those three recommendations that Gertie's led out, are we all happy with those? Thank you, colleagues. Okay, fit and proper persons policy again. I think we've had signs of this before, but Gertie, anything you want to add?
Yes, thank you, Chair. I've provided here the updated fit and proper persons. We did have some feedback through board, and we said we would do some additional amendments after the March board. This is a clean copy, but if board members do want to see the full track change version, I can share upon request. So it updates our fit and proper persons policy. Recognises that we should have fit and proper persons checks for those colleagues who regularly interact or influence the board discussions. Clarity around the deputy director posts in terms of their appointment, and then we have added in the wording as requested around failure to prevent fraud. I think particularly just to pull out and ask, because it was noted last time, is that we have referenced in the fit and proper person policies that where there are any areas of concern, that they will be dealt with in line with the timelines of the appropriate relevant policies. So I think I would leave it at that, Chair, but very happy to take any comments or queries.
Okay, any comments or queries? Hina.
It was just a comment to say that it is effective because I've recently gone through the whole process and all of that was met and done in line. So yes, well done.
Thank you. Thank you. Great feedback. Any other comments or questions? No. So are we happy with those additions in terms of the posts that we're adding and also the additional wording? Okay, perfect. Thank you. We'll move on then until Siobhan joins us. We'll come back to Freedom to speak.
Yes, I've sent her a message to tell her ahead of time, Chair.
Okay. So let's move on then to the Quality Committee. So again, we've got meetings from the 20th of April. Chris, anything you want to for our attention?
I'll just catch up.
As you microphone on as well, Chris.
As you can see, there's the record of the meeting or the AAA report of the meeting. There are no alerts raised, but I wouldn't want anybody to interpret that as there aren't a number of significant issues which have been dealt with. I think the interpretation of that is that where there were significant issues, the committee satisfied that there were action plans or mitigations in place for those controls for those risks. So I wouldn't want anybody to misinterpret that. We talked about board assurance framework and we've talked about a number of other issues which are on here. We'll come to maternity, we'll come to learning from deaths later, but both of them were scrutinised in some detail at the committee chair, so we might want to take the papers on those issues in that context. In terms of future quality committee meetings, we have over the past years taken quality committees a virtual meeting. There's been some discussion with Caroline, quality governance, and the other non-executive members of the group, and the proposal is that we start to introduce some face-to-face in-person meetings for the future. I think that will change the dynamic and allow a proper additional degree of scrutiny. I think actually the virtual meetings work quite well, but I think there's something a bit different about meeting in person, which will help us. You'll see that there is reference to changing the terms of reference. The practice has been for the quality committee to meet every 2 months. So we've been having 6 meetings a year. That isn't, the terms of reference are just catching up with that really, because they currently say, I think, minimum 9. So what we're saying is a minimum of 6 meetings. In practice, the committee will meet more often than that and may well have interim meetings to look at particular issues or do deep dives. So I just make that point that's on the, because it's referred to in the AAA. Other than that, I think we've covered issues. I didn't get a chance to acknowledge the performance out of it, but I'll do that now, Leah.
Thanks, Chris. Any comments or questions on the quality report? No? Okay, thank you.
I should just say the mortuary. Mortuaries, it's important to know that we've seen the annual report on the mortuary. I always think mortuaries are something you should pay a lot of attention to because they are potential risk areas. So we have, just so board members know, we have looked at that in some detail.
Brilliant, thank you. And that's noted in the issue section, isn't it? Right?
Yeah, it is.
Issue authority compliance as well. So,
it is.
Thank you for that. Okay, if there's no other questions, that's for us to note. We have to do that. So we've also got the perinatal palsy surveillance report. It's not joined us yet. We are ahead of time, so we'll again in the same way when she arrives, we'll pick that up at the appropriate time. And then we've got learning from that 16.3. I know this is B2, the quality committee, but I think anything you want to add?
Thank you, Chair. So in brief, we've discussed where we are at this quality committee in a little bit of detail. Our mortality outcome data continues to improve. This is a discussion we have more or less every quarter board, both from a national and HSMR perspective across the board. Mortality education that happened yesterday. So Professor Mohammed came, gave a very good talk to us in the morning, and then in the afternoon we did a deep dive, specifically on our approach, our mortality outcomes, etc. And the team are putting together a few themes and we'll bring it to the board to review national and see the presentation on that. And so we'll do it here, we'll have it for the next course is what's going to be there. I think the only other thing I would draw out is the fact that there's been a bit of a deep focus on abilities in people with learning disabilities. And learning there, but we are working on how we ensure it's embedded in terms of how we can look after that vulnerable group of patients and to extract some learning from that. Otherwise, there's reference to some of the like the organisation as examples in there.
Thanks, Vic. Any questions or comments on the learning from deaths report? I've got yeah. All right, okay, thank you. I have to go right down the list to find you, even though I know you're next to me.
It was just to say that even though that session was from yesterday, I've already had feedback this morning about that session where people are having the habit, and just to say, you think there might be some merit if there were board members available for that session, there might be a merit for a future workshop potentially around some of that, because it clearly is quite impactful in terms of what he has to say.
Thanks, it was very impactful. We actually have had a very specific discussion with him around board member involvement, and essentially we follow up to see whether we might have also with one of the development days, but we think that there is merit in board exposure to this, and also a little bit of targeted additional workshops for specific things, something how we can possible.
So this was to ensure that our methodology and our approach to measurement accurate and in line with national, isn't it? Because our performance actually is really strong, and I think there's a question about whether or not we need to just understand that and have some external validation, which is some tests coming to talk to us about that, and that's what will await the outcome of in terms of that report. But this, the early signs are that that was a positive experience to have your approach.
I think it was very positive for colleagues in general. The answer to the link between data and outcomes and the mortality sort of indicators are a bit more nuanced and complicated. So it's something to share with us, and I would recommend that we have it.
Julia.
I previously worked with Professor Mohammed Ahmed, and I would highly recommend that people, because one, he's very, very smart. He knows what he's talking about, but he makes it very simple. And it is a question that we've debated here at board on a number of occasions, so actually being able to articulate the answer to that in a way which demonstrates some insight is probably a really important thing to do, because it is a really important measure that this is a case note review of deaths and our coding data. So even if you weren't particularly interested in mortality data, coding, there's some really interesting things which I think are important for all colleagues to understand and not just sit and think.
Yeah, thank you, Chris.
Yeah, the simple question is, why have we moved from a positive outline to the negative outline to a positive outline of this in such a short period of time? There's loads of dead interesting things about this. When I used to head up the have responsibility for the Dr. Foster unit, I knew all about it. But the simple question is, why have we moved like that? And I don't think that's a particularly complicated question, but I just think we need to have that assurance.
Yeah, presumably we'll get that.
Yeah, hopefully.
But final comment about that is it is a bit nuanced in terms of conveying to us that maybe the link isn't as direct as sometimes we frame it. And we can have a wider discussion about it when we bring it's that link. I think we just need to keep in mind is not as direct as sometimes.
Thank you. There's a couple of three recommendations in relation to the report. So note the learning and associated actions, note the SHMI data. It continues to improve, although it's still below the national average. And out of hospital SHMI is within expected range. And then note the associated national site framework target achievement of 42. But there is a risk to the sustainability associated.
So can I just throw in one final reminder, just because this sometimes catches us out when we have sessions including the national average is what you want to do. So
it's supposed to be below.
Yeah, so just to say that we are trying to confirm national average is what we do positive as opposed to negative.
Thank you. Okay, are we happy with all of those recommendations? Perfect, thank you. You're welcome, Shabana. You'd be surprised to know that we're ahead of time. So which is why we skipped on ahead, but we've left the freedom to speak up and before you join us, so we're delighted to have you with us. Obviously we've had access to the report beforehand and it's been to be an education, but great to have you with us at the board so that we can ask direct questions and you can highlight anything that you think is important for the board to hear. So thank you.
Yeah, thank you very much, everyone. I can see a few new faces. So I'm Shabana Sadiq and I'm the Freedom Speak Up Guardian for Northern Care Alliance. So I'll take the report as read. Just a couple of highlights from the report. So we currently have 2 vacant posts for guardians. In September, we will have 3 because one of our guardians will be leaving NCA. It's crucial that we recruit into these posts to ensure that there's cover across all groups and also that cases can be managed effectively, colleagues can be supported, and also we can continue to run our awareness sessions. 31% of our cases reported inappropriate behaviours. So it's, that Freedom Speak Up have been involved with the Unwanted Behaviours campaign. So it just shows that it's pivotal that we continue to deliver that campaign. The third point is that I just want to say a huge thank you to our OL&D colleagues, our guardians, our champions who have worked so hard to try and meet some of the targets around delivering awareness sessions to the 20 bottom teams. There was some difficulty in engagement from some of those team leaders. We've done a lot of voting and we've been running around NCA trying to run these awareness sessions so everybody is aware of what Freedom to Speak Up is, and that it's everybody's responsibility to help colleagues to speak up and for managing and leaders to listen up to their colleagues, and then more importantly to act up and follow. So that's been really, really good. And I've been in post, in the lead post since September, and in 7 months we have achieved a phenomenal amount of work, and I couldn't have done that on my own. So just want to say a huge thank you. Thank you to Gertie for giving us this direction as well.
Brilliant. Thank you. Thanks for that, Shivana. Any questions or comments on the Freedom to Speak Up? It's important that we hear it directly at the board from Shivana as our guardian, and she has access to the board to raise any of those concerns specifically. And it sends a really important message, hopefully to all of our colleagues, that we are interested in the board in hearing from our colleagues and what their concerns are. Gertie, did you want to add something?
Yeah, as you say, Chair, I think it's really important that we see and hear from Shivana rather than it filtered through myself or Karen as the lead non-exec. Speaking up and having a healthy speaking up culture is really, really key to a safe, positive experience for our patients, our communities and our colleagues. And I actually say, you know, in the short period of time, you know, Shivana has only been 7 months in post. She has shifted the awareness, the understanding and the conversations about speaking up significantly, from meeting every new colleague who's coming into the organisation to have that personal face to speaking up to really making it okay to speak up. Taking part in the leadership development programs, the senior leadership development programs, engaging with our new leaders, you know, and Shivana is very happy to hold us to account. You know, it doesn't matter what your job title is, Shivana will hold me to account. She will speak to Owen and raise issues with Owen, with Leah, Julia and Rafiq. And, you know, we've set up a process now where through the operational nursing and medical lines, the deputy directors all meet regularly with Shivana. So we should see some real traction. We will be doing some development work in terms of realigning and bringing together our whistleblowing and speaking up policies. And we've talked about a number of times here about having really clear timelines and metrics for communicating with colleagues so that people are getting regular feedback. But I think it's really a testament to Shivana's passion for a good patient experience, a good colleague experience, that our speaking up is really shifting forward.
Thank you for that. Okay, I've got Rafiq and then Owen and then Hina.
So my thanks for Shivana. If I may take the opportunity just to thank Shivana for what she's doing, and just to acknowledge that she's worked really hard to ensure that as executives, we're working a little bit more smoothly with her to ensure that there are timely responses for the challenges.
Yeah, thank you. Owen?
Yeah, I think for me, just first of all, a note of caution. I think it's really important that we don't see Shivana as like a single point in respect that we continue to understand that it's all our responsibilities around this. And I would do it even better if, in terms of where we need to go, the response times to conservative get ready are still not sufficiently where we need them to be. So I think it's important that we do recognise some fantastic work. Shivana and the wider group of colleagues have been doing some really good work on this. But I remain more comfortable with the need here, how we face people around the timelines around some of this. And I'm hoping that we will continue to have some focus around that. Thank you, Chair.
Yeah, absolutely. And of course, that's not Shivana and her team's responsibility. That's everybody else's responsibility to respond to those issues. And whilst I think we've noted some progress in relation to that, I imagine it remains a challenge. And as Gertie said, keeping people informed in terms of where we're up to and what progress has been made is really critical for that confidence in the process and the culture of the organisation. So yeah, thank you for that. Hina.
Thank you, Shannon. That was a great report. I guess this might be a bit more aimed at Gertie, if I may. So we know a huge part of what you're seeing is inappropriate behaviours and attitudes. And I wonder whether we can really try and hone in on that and find where the hotspots are and do some targeted work in those areas. So, one of the parts of this is obviously people feeling comfortable and able and confident that the organisation is listening and wanting that feedback. But then to actually see what's happening as a result of that feedback is the second part of that process. And I just wonder whether we are able to demonstrate that to the people that are coming forward, because it then feeds into a process of encouragement, seeing some actual differences being made on the ground. And it's a separate angle to what Owen was saying, but it completely, all of that coming together makes it everyone's responsibility, and people really do feel supported in the workplace. Thank you.
You're absolutely right, Hina. And actually what we're seeing is that early hotspot identification with the Speak Up team, the OD team, the HR teams, working closely with those leadership teams, looking at where you can see metrics going off and putting in an early behavioural impact really, really soon and quickly. And I think if I would just follow what Alan's quote, because I forgot to say it, and it is absolutely key that speaking up is all of our responsibility. Does every single colleague in the NCA understand what it is to speak up? Does every leader and manager understand what it is to listen up and to follow up? And we will be taking the paper into the People and Education Committee and the Trust Leadership Group to mandate the national Speak Up training for all of our colleagues, so that we're really clear about everybody's responsibility in that respect, that we understand it and we know what it is and we're responding to it really quickly. We will be bringing that through quite soon, so that then we can start from July to have a trajectory to achieving that.
Could I please correct, Chair?
Yeah, please.
Yeah, sorry. We're also doing a lot of triangulating work, looking at data, so the National Staff Survey. So we're working with OL&D and also colleague experience to identify those teams where that speak up culture isn't there, where staff and colleagues have stipulated this in the National Staff Survey. So we're actually going out doing targeted pieces of work with those particular teams. And we've already done that, identifying 20 bottom teams within the organisation. We're now doing it with the LM model. So we've identified each group from each clinical group, each team from each clinical group, touching base with them, and where that, whether it's engagement or whether it's behaviours that they've highlighted in the National Staff Survey, or that psychological safety isn't there, we will then go in as OL&D, as Freedom Speak Up, to go and do that work with those teams.
I think it's also worth saying that at our last public board session, we had an update about the team that needs to work around violence and aggression and adopting a kind of trauma-led approach to that. Accepting that some of the behaviours are actually between colleagues, but there's also a lot of behaviours that are coming from the people who use our services as well, and how we handle that and respond to that. And that's a really positive kind of update to the board in terms of some of the things that are progressing, but it's definitely still an area of focus for us. We know that our colleagues are telling us that, which is hence the unwanted behaviours campaign. But it sits alongside all of the other things that are running. A bit of a point to raise. Thank you. Anything else? Oh, Carmen, sorry.
Just to say, looking forward to working with you, and we've got a catch-up meeting on Monday, Shannon and I. And I think it's important that as we go around the organisation and we meet colleagues, that we ask the questions about how do people feel about anything that they have concerns about, and do they know what to do, and how is that responded to, and we ask those questions directly. And that doesn't mean that I don't think you're doing it, because I think everyone does do that in their own way. It's just a little reminder.
Yeah, that's right. And of course, thanks to Aziz again for being the Freedom Speak Up champion, who's handed the baton over to another one to Carmen to pick up. So I'm sure you'll make those good connections. Anyone else anybody wants to raise? So thank you so much for all that you do. I know you do have a lot of passion for this work, and obviously we meet regularly. I know you get going, so you've got lots of access to colleagues in terms of being able to raise those issues. But I think it's your passion to go out and make sure that people know about the services that are offered that have led to the improvements that we see, which is, a good thing. That it's not a numbers game, it's improving people actually. It's about how people feel, and if we get more people speaking up, that's a good thing. A bit like complaints, really, if they know how to do it, and that's part of the challenge that I think you've been dealing with, grappling with, making some real good inroads. So thank you for joining us today.
Thank you.
Thanks, Father. Okay, welcome, Faye. Sorry. We've jumped ahead on the agenda, so I'm going to go back now to the policy section and look at our perinatal policy surveillance report. So we know it's been to the policy committee, but again, a bit like with Shivana, there's no substitute for having you in front of us, giving us those assurances around, or not, hopefully it's assurances around things that you've been supported in service area around maternity and gynecology. So over to you.
Thank you, Chair. So I'll take the report as read. There are just a couple of key highlights that I do want to pull out. Obviously, as you say, it was discussed at length and reviewed as part of the quality committee. So I would just like to draw your attention to the NHS resolution upgrade for our maternity incentive scheme year 7. So we'll start with the good news story. So you'll be aware when I came to board, collectively we made the decision that we would only declare compliance with 9 out of 10 due to one area that we didn't submit within the timescales. We provided mitigation to NHS resolution as to why we'd missed that one case. And we were upgraded and received the formal notification that we did. We were verified as 10 out of 10 for all of the safety actions. I think within that, it is important to note that MIS Year 8 has just been launched, and there have been a number of webinars that many of the team have been on. It does look significantly different to MIS in previous years, much more around quality improvement and the system working, and much less of a tick box type approach. So really looking to strengthen that quality and safety around maternity and neonatal services. And many of the areas that we'll need to be working to align to quality improvement and improvements within services rather than monitoring of data. So it's important that you are aware of that. The way that the LMNS also work around MIS will be changing. So you'll recall that historically they reviewed our evidence and provided support around our submission. They won't be doing that this year, and the responsibility will purely sit within trust. So again, it's really, really important that at board you are getting the assurances around the evidence that we are providing, and that we are meeting all of those safety actions moving forward. Since writing the report, we have been re-reviewed by the LMNS around our Saving Babies' Lives. So you'll note within the report there was a number of areas that we were partially compliant. I did receive an email on Friday to say that we are now fully compliant. So we've managed to pick those actions up in that short period of time and have been re-reviewed against our evidence. So we are now fully compliant. Saving Babies' Lives will have less of a less oversight really as part of the LMNS. They will be moving forward to the maternity care bundle, and maternity care bundle will need to be fully implemented by March 2027. So I will be providing you with updates on the maternity care bundle moving forward. I think one of the areas that we discussed at board at length is our stillbirth rates. And last time we kind of raised the flag that they weren't where we wanted to be, and we'd seen a bit of a trend in terms of that significant trajectory. I am pleased to say that it does seem to be increasing. We seem to be going back to our normal variation.
And what we are looking to see is that our 12-month rolling rate will then go down next month, because you'll remember we had that peak in May. So over the 12 months, we'll then start to see that drop back down again. And we haven't had any signals as part of the maternity outcomes signal system again, which is positive. So there's been no external escalations around our stillbirth rates in terms of that assurance. So they're the real kind of highlights that I wanted to pull out, and just to recognise that since the writing of the report, some additional work has also been done around our maternity triage. So maternity triage was really a high risk area for us, and we've discussed that at length in a number of quality meetings and safety meetings. And we have now had a solution to that doctor oversight between the early evening hours. So we are looking to see that that improves our compliance with obstetric reviews, but also improves the patient experience, which has been particularly poor when ladies have been delayed to see a doctor in triage. So we're going to really closely continue to track those things to make sure that that intervention is providing us with the appropriate assurance.
Thanks for that, Faye. Questions or comments? Chris?
Firstly, it's really good news on both those compliance issues, Faith, isn't it? I didn't know about the saving baby for that, so that's really good to hear. MIS as well, because MIS has financial consequences, doesn't it? And I can't just remember the amount now, but it's quite a lot of money, isn't it?
It is a lot of money. So I think last year it was 1.2 million. So it depends on how many organisations are compliant as to the premium. But yes, it is a significant amount of money.
As I understand it, it will go up next year, and with the changes to the scheme, there'll be with a greater focus on culture as well within the scheme. Is there anything? I mean, bearing in mind that there's that amount of money and income associated with it, is there anything that you feel needs to be done in order to sustain our compliance with MIS or the others, for example?
So I think within FACT, we have the people to be able to make sure that we deliver it in terms of the workforce. I think one of the key messages, again, from MIS Year 8 is that it isn't just the directors of midwifery's responsibility to deliver it, and there is that shared accountability. And I'm really pleased with the leadership team that we have in place. So I don't have any doubt that collectively we will be absolutely focused on it. I think it is a significant difference, but everybody who's needed to attend the webinars to understand the requirements has attended. So it's not a lack of understanding of the responsibilities. Looking at it at its high level, I don't think there are any significant risks to the organisation if it's not delivering it, because the bottom line is it should be business as usual. We've looked at culture, we've done an awful lot of work around culture. The maternity care bundle, we've already started work around to deliver that by March 2027. We've had an awful lot of investment in our workforce, both midwifery and obstetric, of which we're really grateful for. So we don't perceive that there's any high risk indicators or areas that we wouldn't be able to achieve. The key to it is focus and sustainability.
Brilliant, thank you for that. And congratulations on your appointment in the new clinical service unit as well.
Yeah.
Seen you since you've been in your new role, so well done. I've got Tim and then Julia.
Yeah, just on the MIS one, the maternity incentive scheme, the LMNS are being kind of taken out of the process. Not necessarily want to answer now, but I kind of think we probably need a bit more independent assurance around that process, particularly given the financial consequences. It probably needs something, we need to build something internally around that. Maybe something for the quality committee to think about. So that was just one observation. The other one was, when I was at the experience group, there was talk around the AMAT system, which I know Juliet's briefed the quality committee, and I was kind of interested. It does, the types of questions you can ask through that will generate quite a richer picture of experience. So it's just your view of what the opportunities are with that new system, and whether it's getting used in maternity at this stage.
Yeah, so we're on our 3rd month now for inpatient maternity, our 1st month for outpatient for AMAT. I think the team are just starting to get to grips with it, Tim, because it is new. And we have seen today at one of our quality meetings, those first reports starting to come through. So we either provide us with the assurance that we're looking for or particular areas of focus. And we will use the AMAT data with all of the other data that we have to be able to triangulate patient experience. So, you know, monthly we look at the FFT and that comes through the patient experience. We're continuing to look at our ONA, and we've had some really positive, OLA, observe, listen and act visits in the last few months in maternities where 2 of our wards have got green. So we need to look at the data as a whole in order to understand the experience of women and families accessing our service. But yeah, AMAT will be part of that moving forward. And I think it will take teams a little bit of time to get used to it because it is very new. But the initial view is that they find it a really positive tool. We've spoken about it, as I say, today during one of our quality meetings, because the other thing in the new FACT leadership team is I'm keen it doesn't just sit with midwifery or nursing. So where are the obstetricians in doing those assessments? Where's the ops team? Let's get together and do it collectively rather than it just sitting with nursing or midwifery.
And can we just describe what that is, that process that you mentioned?
So it's a new audit tool that basically looks at the quality and safety of your services. Within maternity, there's 3 different sections, and it's a monthly audit. So you go onto your ward area and look at things around are bed boards filled in? Do women know who's looking after them? Who's their named midwife? Have safety huddles taken place? So I think that in all there's over 100 questions that we need to go through on that monthly basis. So it's a bit of a go into your ward areas, what does it look like? But I am keen that it is an MPT approach. I think that's probably the way forward. And at the end of the month, there's an electronic dashboard that it feeds into that displays your percentage of compliance, whether you're red, amber, green, particular areas of concern. And within FACT, they're then pulling that into reports coming to our quality meetings. So it's something that we're reviewing on a monthly basis.
And that's on the basis of inpatient.
Yeah, and outpatients has just started. All areas across the NCA are using it, and the feedback is that people are finding it really a useful tool. So you'll probably start to see more of it and people talking about it a lot.
Thank you, Juliet.
Thanks, Chair. I think it's really important to connect to a few conversations we've had on the agenda today. One is the piece of work that we're drafting around women's experience of using maternity services, and the presentation we had at the last board where we talked about concerns about health inequalities for women who use services, not just but generally in communities, their health inequalities. We know that what was driving a key part of whole patient experience was in triage and the inability to get a review on time. So I think it is important that we do track through some of the metrics in here around triage with the additional workforce in there to make sure that what we think needed to happen to improve experience and care has actually happened. I think it's been a problem for some time, hasn't it? We should be particularly paying attention to that over the next few board meetings to make sure that we're addressing those concerns in the triage.
Yeah, and also you put in place some specific roles being focused on targeting and our approach to health inequalities to understand what that looks like. So a bit about that.
Yeah, so we've employed a matron into that role. So she hasn't yet started in post, so she's just moving from her old post into her new post with changes through CLM. And her role is to have that focus around patient experience, particularly in relation to our diverse population, both in terms of, ethnicity, but also deprivation, and also how that then links to staff experience. So we have a retention midwife that I'm sure you're aware of, who's in post within the maternity service. So those two people are going to really work closely together to understand colleague experience, but also to understand how that relates to women's experiences. Because if midwives, support workers, doctors feel particularly burnt out, don't feel that they're cared for, don't feel passionate about coming to work every day, that will affect women's experiences. So the two need to link together and work very, very closely together. And yesterday, obviously, we celebrated International Day of the Midwife, which is a really special day in midwifery, and gives people the opportunity to reflect on. Sometimes it is hard, but actually we still come to work every day to deliver the very best that we can. So, the next stage really in terms of the health inequalities is pulling all the work that we have done together into one place and saying, what have we done? Have we made a difference? And what do we need to do next?
Great.
Faith, you rightly drew attention to the importance of the multidisciplinary team. And in the report, there's reference to some success in recruitment in obstetricians, but the sort of doctor involvement has come up a few times in what you said. I'm just wondering what more we might be able to do, because that feels to me like a bit of area that we need to make some more progress in. Recruitment to permanent roles in order to be part of MDTs, in order to enhance the experience, provide that sort of extended cover and so on. Just feels like that's not an area we're right on to yet. Is there any more we can do to support you?
So I think if I reflect on where we were 3 years ago within the organisation in terms of that medical oversight and engagement within maternity services, we've moved a significantly long way. And I think we've seen real improvements around MDT working and those relationships. I do believe that, we need to be somewhere where obstetricians want to come and work. And that's really, really important. And that comes from opportunities to develop their careers, specialisms, specialist clinics, all of those things that will attract people to come and work for the NCA. I think CLM will help us with that. And I'm really delighted with the recruitment of our senior team within CLM. And I think some of the changes that we need to make around medical leadership and rotas and things like that will really start to be pushed forward now with the support of the CDs within CSUs as well. I think we are very aligned in our vision on what that needs to look like. I think CLM gives us the opportunity to start moving some of that forward now at pace that will make a difference.
Of course, reputation for training quality is also very important in that, isn't it? So maybe that's something we could look at as well, because I know those reputations vary quite a bit.
Yeah, and we did have some really positive GNC visits for maternity and gynecology, obviously because they're a joint role. But that doesn't mean that everything, is perfect and we can't continue to make those improvements. So staying close to that is really, really important.
Okay, thank you for that. If there's no other comments or questions, thank you for joining us, Faith. And we've got two recommendations. One is to see the update, which goes to the quality committee, but also to note that that's delegated. But again, I think it's really helpful for the board to hear directly from you about the progress that's made. And whilst we can celebrate, it doesn't last long, does it? Because you're on to the next year in terms of the maternity and maternity scheme and what's next. And it sounds like it's a challenging year ahead. But we look forward to hearing how that progresses. And great to hear your confidence in the clinical leadership model and the changes that you've made at your director level and your clinical service group. It's great that you've got real confidence in how that's going to move forward as well. Okay, thank you very much. Thanks. Nice to see you. Okay, colleagues, let's move back on the agenda to charitable funds. We haven't got Rachel with us today, but the report's there for colleagues to know. Are there any questions? Oh, sorry, there's two items. Reading ahead in my hurry to progress through the agenda. Okay, so back to, sorry, onto the quarter section. Tim? Okay, so we've got two reports, patient service user experience report and the learning from experience. Are you going to take the two together? Yeah.
I'll just take questions. There's a lot of detail within there. We received from a quality committee. We've referred to some elements of that throughout the conversation. So I'll just take some questions.
Perfect. Thank you. Any question on either the patient service user experience report or the learning? Pretty comfortable with that. It has had quite a detailed review at the quality committee.
That's correct.
Anything that you wanted to raise, Chris, in relation to the assurance that you received at quality committee?
I think we received, good level of assurance and had a good discussion about this issues and noted the importance really. And it's an area that we want to put more attention to. I think that was the conclusion, wasn't it? That we focused a lot on the sort of safety and the effectiveness side of things, but getting escalation and triangulation of experience was the thing we needed to do next time committee. But some great, as ever, some great work being done. I think the thing was to bring it together into a sort of program.
Okay, thank you, Carmen.
I just want to say it's a really great report to read. It's very easy to read, and I think in terms of being in public domain, it gives a really simple way of being able to see what we've acknowledged has been raised with us and what we've done about it. And apologies if this question's been asked at quality committee, but how do we get that information out to our workforce, to our colleagues that say we do this in this way, and therefore we take account of what's been brought to us? It's just might be that I don't know the answer to that question.
Most of the changes that we see are led by our staff.
But what, in terms of the wider population, so the staff who lead it, you can tell it's the staff led, and that's great. But if you're not involved in that process, how do you know we're doing all this great stuff? Because it's great stuff.
Yeah. So for a variety of different ways, certainly one of the things where we're doing some improvement work at the moment in nursing is as we're coming to our new leadership model, teams getting together more. So we're getting different groups of workforce together to do some shared learning, shared implementation. And we looked at the AMA, some of what's being developed in what does good look like is derived from some of this. So we're getting teams to go out much more and starting to do some peer reviews of some of these as well. So something that might be working well one area, we'll get those colleagues to go out to different areas and look and see those things as well. So some has been happening, but I think with what we've created in the structure, but also some of the tools that we're using, it's now helping to kind of influence what that looks like. We mentioned International Day of the Midwife, but International Day of the Nurse next week on Tuesday, and we had nominations from clinical. I've got tickets to go down, and they've been bought. Got another ticket to join the Florence Nightingale Foundation. Got 2 tickets. We're taking down the most improved. The award leader's got the most improved award as nominated by her colleagues, and some of this stuff is this stuff put into practice. So having an award which wasn't delivered a great patient experience, learn from what they've done, and then get into the most improved area. So we're through a variety of different ways of trying to put kind of more focus on acknowledgement of the work that people are doing, sharing the work that people are doing, and then trying to adopt it. So more to do, but through a variety of different ways.
Thank you.
Okay, thank you. Ina, and then Owen.
Mine was a general comment, actually. I think it was a brilliant paper. It's great to see some of the work. And whenever I read things like this, it's always really interesting to see what matters to patients and their experience versus what we might think is important. And, you know, some things like having access to being able to get your hair cut, having Wi-Fi ports, having access to water. And it's just for us as a board not to lose sight of those things are so incredibly important to the experience and the stay and the mental health and how the whole journey is. And I think it's brilliant that these pieces of work that we are doing and investing is celebrated and is shared widely, and we encourage those kind of suggestions because some of them are fairly easy things to do, but we don't necessarily see it from that point because sometimes we can get so focused from a patient safety and quality of care and the finances, etc. So it's just to make a comment around that.
I think it's a really important point. It's the difference between what's the matter with you and what matters to you, isn't it? And I think that's the crux of what you're describing, which is really important. So thank you for that. Oh, wait.
Yeah, so we check back with Karen. In your question, I thought I heard about sort of really great work doing here. But if you're a resident, how do you get to know about that work? Or is that not what you said? I just want to be really clear because if part of what you're saying is it's really good stuff here, but who other than the people actually maybe doing it directly involved gets to hear about it? I'm not. I just want to be clear that
My question was about workforce and colleagues.
Yeah.
But I think your question's a better question. And I think it's really important that we know as well how that gets out to contribute and their families, etc., and the use of our service. So that would have been a better question. So I'll take that learning.
You can't answer that. I think the answer is we've probably got work to do on that because it feels a little bit like better kept secret sort of stuff. And it's precisely the stuff that I think is of people beyond the workforce we would want them to know to help the confidence. So I just think there's maybe further work for us to do so that we would be receiving that question, be able to give quite a comprehensive answer.
Yeah. Okay. I mean, I think maybe that's to Julie can help with Julie's team. But I guess one of the challenges that I think we posed to Juliet when you came with patient experience information at previous board meetings was let's see it all together and what does that picture look like, and that's what we've got here, which is all of the elements of, and I'm sure there's more that we can do around that. So friends and family tests are great, you know, results are really high, but I don't know what the response rate looks like, for example, and it's good that we're, you know, driving some of the understanding that we have of what the experience of people who use our services is. And what we've seen here in this report is a really kind of comprehensive assessment of all of that together, which is helpful. I guess the next thing is then, so how do we share that and what we're doing?
Yeah, and without going, there's quite a lot more work going on. So if it's what the board wants to do and what the Technical Quality Committee, you can just not stick to a same format, but just some of the work we like with, you know, the bit where we're going to get real-time patient feedback. What does that look like? So you can, you know, start just bring a report in here about patient experience, but think a bit more creatively about what that might look like. And so, you know, any other board members have got some suggestions, and we can present it in any way. But I think seeing it presented in different ways. One, you know, which can be very data-driven, the patient experience surveys, friends and family. Another one which has got a bit more qualitative information in, so it gives a bit more context to it. We can certainly think about and work with Mrs. Chair of Quality Committee about what that might start to look like.
Brilliant. Thank you for that.
Just reflect on some of that discussion. Clearly, for the Quality Committee, we're looking to expand the space occupied by this area, but it's just reflecting on the sort of external understanding, because there is this phenomenon, isn't there, about organisations having, trying not to use the word reputation, but the view of organisations externally, and the fact that public and also staff reputation takes time to change, takes time to catch up with the reality. And I'm just linking that in my mind with public confidence, patient confidence, regulator confidence. So I think this discussion is really important, and it's important we do was pursuing through quality committee and report to the board, because I think it's about that confidence, about people understanding the progress that's been made on some of these issues.
Good, thank you. So there's a series of recommendations on both of the reports. So 3 on the patient centre user experience, and 3 on the learning experience. So we have to agree those. Yeah, thank you, colleagues. Okay, so now we will move to charitable funds at the appropriate time. So is there any comments or questions on charitable funds? And I know Carmen was there, so you may not be able to feel that if there are questions or Julie. Lorna.
Yeah, thank you. It's in Rachel's absence, I think it's a comment, and there's a direct link with the papers that Juliet's just presented. So that patient experience, our staff experience, if you look in the assure section and you join that charity committee, that the impact and the ability of linking directly that patient feedback and patient contribution to a very, very small charity with a very tiny number of staff actually is phenomenal. And it's a pleasure to sit on that committee and see the level of impact and the individual activities that are done by the team. And actually reading it on a set of bullets just doesn't bring it home. And I think if you're interested, I think we'll get the charity team to share that with other board colleagues, because it's a great little slide deck that really talks about the things we do. And there's a thank you to the members of the public and patients that contribute to that help us do that. The other key thing is that team's gone through quite a lot of change in the last year, and the fact that it's delivered quite a lot of activity over this last year that is directly linked to what feedback we're hearing and working with colleagues is really empowering. And the final bit that's worth commenting, it's been a lot of work about launching a charity lottery. It's in the decisions in the AAA, but actually we shouldn't underestimate how much time and effort and thought's been put through that. You know, that depth into all sorts of concerns about gambling and issues, but the team have really worked that through and thought about that, and really again worked with our colleagues across the organisation, make sure we've got the right governance in place. But that again will be allowing us to help patients, particularly in an economic climate where we can't always do things ourselves. So being able to add little bits of value that make it, Chris's point, a difference between feeling confident to come into one of our sites and be treated, it's really phenomenal. Thank you.
Thank you for that one. That was really helpful actually. And it's not often we get AAA reports with that amount of assurance in there and some good things. So thank you for bringing that to our attention. That's really helpful. Okay, and they do fantastic stuff, and we've heard directly from them on our board recently. And we've got a session with our governors as well on the charity very soon. So again, hopefully they will get ambassadors out there for the charity as well, and share some good work. Okay, thank you. That's for us to note. Okay, so we've still got some items on the agenda, but we are at the sort of well, past our lunch section because we're ahead of time. So I'm going to just take the audit and risk section, and then I'm going to stress that we take a break at that point. That's okay with me. So Tim, audit and risk report from the meeting held on the 23rd.
Yeah, there's a couple of recommendations for the board that I'll come back to. I'll just present the report. You can see from the items considered that it was a long meeting dealing with some important stuff, principally the end of year accounts, in terms of the committee seeing those. And I also flag up that Suzanne organised shortly afterwards a session that Chris and I could attend, where we were doing more of a page to kind of do a bit more scrutiny and understanding of some of the judgments and the estimates, provisions, etc. that form accounts. Another one I'd just speak to, because it is one of the recommendations, it's the compliance with the NHS provider licence and our self-certification. That's appended to the AAA report. Essentially, this is for the board to kind of consider and confirm, but see from that appendix that as a provider of commissioner requested services, the NCA has a reasonable expectation subject to strategic commissioning decisions that require resources will be available. So I'll come back to that in the recommendation. Now turning to the rest of what we consider the meeting, just flag up, there was one limited assurance report with regard to bank and agency. Juliet was there to kind of talk to the response and the action plan in respect of that. We had the head of internal audit opinion, which is a moderate assurance, which is the same as last year, but we have a trajectory of where we need to focus on improving. Other areas worth picking up would be one in respect of digital governance. The committee has a more enhanced role in oversight of digital governance, and Lorna was helpful in kind of setting out the specifics in respect of that and the broader governance of digital across the trust. Our deep dive schedule is under preparation, and that's been supported by Louise Tulloch. And you can see from what's under the approval section, a lot of things that kind of align with the paper that Juliet talked to at the beginning of the meeting with regard to quality governance developments. A lot of the scrutiny has come here in related issues to risk management, governance framework, refreshed approach to BAF that Tim's spoken to, and the operating manual accountability framework where we saw the first version. So there's been quite a bit of non-exec scrutiny, those important pieces of governance foundation. So just coming back to those recommendations, obviously receiving the report, but it's first of all delegating authority to the Audit and Risk Committee to approve the annual report accounts on behalf of the board, and to consider the declaration that I spoke to in the second bullet point in the AAA report, but we're happy as a board to confirm that statement.
Okay, thank you, Tim. Any questions or comments on anything that is in the report or is raised? Recommendations? No, we're happy to approve those. Okay, thank you very much. Okay, I'm going to actually plough on if that's okay, because Tim's just advised me that they should be relatively short items, so we're going to see if we can make some progress on other items on the agenda. So we've got the refresh of the standing financial instructions and detailed scheme of reservation delegation. Suzanne, anything to add in relation to that?
Don't worry, I won't be doing the line by line review. Financial instructions and scheme reservation delegation. We did that, didn't we? You know, audit committee, audit and risk committee. They're here for approval by the board on recommendation of the review that was undertaken to audit and risk committee. We've done a thorough review of the SFIs and sword. Basically because that's good practice, but also we've made some significant changes in terms of that curriculum model. We need to make sure the frameworks that wrap around financial governance are appropriate to support those as well. So we have done a very detailed piece of work this year. I just wanted to mention that alongside this, we've done a training needs assessment of DNA to ask the organisation what they need in terms of training, whether that's around anything to do with finance or financial governance. Had some good responses back. The standard financial instructions SFIs will be a key component part of the training that we will offer on the back of that, and that will show up in a series of things such as webinars, easy to read guides, and some learning materials, some of which we've already shared as part of the letters of delegation when we discharged the budget delegation to clinical and corporate groups. Which feedback is positive in terms of how that's been received. But this will be a really key area for us. It's a really critical document that we all need to understand and how we fit within it. And the final point is that we'll continue to review the SFIs.
Okay, thank you. Any questions or comments on the SFIs or the changes that proposed amendments? Chris?
I think that what makes it very reasonable to me. But just when I was reading it, I noticed that the delegation to some of the clinicians who are now leading the clinical groups and so on, and it may well be the first time they've had any budgetary responsibility. So I wondered if you considered that was not a risk, but something that needed support or training, because it's up to about £500,000, I think, in some cases. I mean, I think it's appropriate, but just have they got the appropriate support to do that?
Yeah, absolutely keep part of our consideration when we've done the last delegation, which I'm more than happy to share because that sets out real clarity around responsibility and accountability. But we certainly haven't just thrown it over and said over to you. You've coupled that with quite a lot of training and support and development. So as part of the clinically led model, we restructured the finance team as well, and now they're directly aligned to the clinical groups and are providing that business partnering approach to each of those clinical groups to make sure they fully understand the responsibilities that they're now accepting, you understand how the budget has been created, they understand the ask in terms of cost improvement. But that won't be a one-off, Chris, you know, that's going to be again as part of the TNA and training and how do we ongoing provide support to those teams to be able to deliver what we're asking them to do. It's a critical objective within my finance team is to make sure that we make those clinical led groups a success. You know, we take that really, really seriously and making sure they're equipped to take the responsibilities that we've got. So yes, it's shown up in that way, but as also part of the clinical led model training and development and support package that's wrapped around under Pete's leadership. We've made sure that there's plenty of opportunities for them to get the support.
Okay, thank you. Any other comments or questions? So we've got two recommendations there. One is to approve the amendment and the other is to approve the support in terms of the behaviours training that we've provided around the changes and communicate that. Let's do that. Okay, thank you, colleagues. Let's move on then to item 19, which is governance. Tim.
Yeah, so just as colleagues to take the thoughts, right, Chris has already alluded to some of the changes that have been proposed from the quality into the paper. Clarifies that also to know proposed changes to membership of board subcommittee.
Okay, any questions or comments on the paper around subcommittee? No, we have to approve those. So there's some big recommendations there and the frequency and the membership and the subcommittee in terms of reference. Great. Okay. And then the second item under governance is the ratification of the decision that we took under emergency powers to appoint Jeff as the senior independent director. So we're happy to ratify that decision for the emergency powers, but we need to know your interest at this point, Jeff. Okay, everybody agree? Yeah, thank you.
Yeah, on that, we're going to thank Carmen for a really clear handover, benefit and her work on this role. I did appreciate it, so.
Yeah, absolutely. Many years of service in senior independent director role, so really appreciate it. Thank you for that excellent project as well. Okay, great. Let's move on then to the council governors report. So that was for the meeting held on the 23rd of March, and we take it as read. So anything there to raise? That's supposed to note. Thank you. And then we've got the Green Oversight Group, and this is a note from the meeting held on the 3rd of March. Is there anything that you wanted to bring to our attention?
Thank you, Chair. So again, in brief, just highlights there are some notes in there about presence of patient representative and staff engagement with the staff representative. We're engaging with colleagues from the background and with patient representatives as well. Probably also worth just highlighting our next meeting will be in June. At that meeting, there'll be a review of where we are with recommendations, to bring a recommendation toward us to what next steps should look like, and it's done in light of also the expectation of the candidate to be independent.
Okay, thank you. Any comments or questions on the Green Oversight Group? No? Okay, thank you for that. So I've got one item of any other business, which is the annual review of medical appraisal and revalidation.
Thank you, Chair. So, I will speak, just to highlight to colleagues that there was an error in uploading papers. So those of you who might have seen the paper sort of earlier, we've seen that at previous version. Essentially, this is the report that we saw at board in September. September was tabled ahead of the submission to NHS England. It was highlighted to the chair that there was one error on that report, essentially related to a number of medical colleagues who have gone through a tribunal process where the original report said 0, and that figure was not the original said 0 to 10. So this is to update the report, make board aware. NHS have been informed, and so have the correct information. Apologies for that error. We changed some of the processes around that to ensure that it wasn't.
Okay, thank you for that. That was duly noted and the appropriate report updated. Thank you for that. So there's also an inclusion in the pack around the closed session information from the meeting that we held in part 2 on the 4th of March and the 17th of March for information. Our next date and time of our public meeting held in public is the 8th of July at, it says 9:30, we may well change that till 9, but for now that's what it is. And then to note the resolution to exclude the press and public from the meeting on the grounds that the subject matters could be prejudicial to public interest by reason of confidential nature of business, which means the press and public are requested to leave this point and bring the meeting to close. Thank you for your attendance. Lovely to see you. And I'll bring the meeting to a close, and if we can reconvene to have one. Thank you.